Okay, everybody, as promised, we're going to get started on time. It's 6 o'clock. I'm not even sure what installment this is of our refresher course, our YSU Trumbull Regional Medical Center combined refresher. We've been getting some great reviews. I appreciate when you guys, when you fill out the forms and send your opinions and everything. That helps shape what we're going to do next. So take an interest in it and you'll get stuff that you like. As always, I want to, mention the COVID-19 response right now. I know our local community is getting hit hard. They keep telling me it's turning around, but it doesn't feel like it. Every time they tell me there's going to be a plateau, numbers go up by 2. So I hope you guys are getting a little better results. As always, I just implore you to keep your PPE, consider vaccinations, and keep yourself and your family and your patients safe. Tonight, we have Kristyn Woodward. She has her master's in social work. She co-authored the psychiatry section in Joe's book. I'm having a little hard time talking today. And has worked in many aspects in her field of mental health. An esteemed colleague. We're glad to have her here. Looks a little nervous, but that's all right. You'll get into the flow of it. It's in your blood. You'll be just fine. So thanks for joining us tonight. If anybody has any questions or anything, of course, as always, just put them in the chat box. We monitor it the whole time. Or if it's appropriate, go ahead and talk. But we don't want to get too much interference. So take it away, Kristyn. Thanks a lot.
All right.
Let me see. Okay. Yeah, let me see if I can. Which one? This one, right?
Yep.
Can you see that, Matt? The PowerPoint?
No, just you guys.
Not yet.
Okay. I don't know why I struggle with this.
I feel like I should know how to do this.
Yeah, you should, Kristyn. Let me see if I can put that there. No. What?
Is there an option like to share?
Yeah, well, let's see. I should know how to do this already. Shut up, Larry.
Kristyn, I'm on my best behavior, so I can't say anything because you're on the line.
Yeah, let's see.
So now we're mirroring your desktop.
All right. Now you got it.
Okay.
Hey, Larry. Okay. And then
Love you, Joe.
You could just do, or you could hit that.
Okay. All right, cool. Okay, so hello, everybody. I'm Kristyn Woodward, like Matt said in the introduction. So I have my master's in social work. I started in crisis work, and I worked at actually Coleman Behavioral Health back before it was even in Mahoning County, in their crisis center, and going into the ER and actually doing the psych assessments. That was where I started when I was in grad school, and then I was in the ER throughout over the years in Columbus. I was at Mount Carmel East, which at the time was like the second busiest adult hospital. So I have always had a little bit of a passion for psychiatric in the emergency room setting and the crises. So I hope today I can go over some of the things, and hopefully it'll be a good next few hours here. So just for formality here, so I just had to put a statement in here basically explaining that the views expressed, information provided today don't reflect my current employer in any way. Okay, so just to kind of jump in here, so obviously we know psychiatric emergencies and mental health is important, but why is this important for EMS? Oftentimes, you guys are the first ones on the scene, first to interact with these patients. And one of the statistics I find interesting is how 83% of people who have completed suicide saw their healthcare provider within the last year. So obviously, you're not the healthcare provider, but that just shows you like these aren't always people that are just sliding under the radar. These are people that are actually being seen. So when you're asking the questions, you're going to be able to identify that there's an issue going on. And unlike most medical emergencies, obviously psychiatric emergencies are often not visible. So this takes a great deal of assessment on your part, which makes it very difficult when you're in the field or in a random bedroom in someone's home. So why is this important? Again, you require a specific set of skills to assess and treat what could also be life-threatening. You don't have access in the field to blood work, urine, CT scans, but your early identification and intervention is super pertinent in ruling out any psychiatric diagnosis versus medical diagnosis. And even just being able to pass that information on is so important. And it must be seen as a healthcare core responsibility. I know it's easy to kind of think like with mental health, oh, like it's mental health, and sometimes we get burnt out very easily, but this is a population that obviously we need to maintain passion towards more so than not. So you guys know the basics. I'm going to kind of jump through some of the slides that are going super in depth with things. But when I talk about a psychiatric disorder, obviously other terms we hear is mental illness. You hear behavioral health. Some of the terms we use for that are interchangeable. Basically, it's just describing a mental condition that's abnormal, often impacts thoughts, moods, perception, orientation, or memory. Judgment's impaired, recognition of reality, activities of daily living are oftentimes impaired. Psychiatric symptoms do not automatically equal a psychiatric disorder. So people can present with psychiatric symptoms doesn't necessarily mean that they're experiencing a psychiatric diagnosis or disorder. And the etiology is still not completely understood. Obviously, we have the brain scans that show lack, excess of different chemicals in the brain. There's a lot of research on like childhood trauma or just trauma in general, and then environmental factors that contribute to psychiatric diagnoses. So for a psychiatric emergency specifically, we're going to looking at presentation of abnormal behaviors. So somebody who is presenting with a threat to themselves or others, or just a presentation that's incongruent with their baseline, a rapid change in cognition. And I'm going to give a couple examples of different people who maybe would present, in a certain way that, I guess maybe, I don't know, like family or things like that, where their information that's being provided to you is going to be so important in making your decision as far as like what the next steps are going to be. Because a lot of times we forget about the baseline and we just see like, oh, there's a 95-year-old with dementia, but what was his dementia like at baseline? So I'll give a few examples of those in a little bit here. So again, common encounters EMS you guys would typically experience would be suicidal, homicidal threats, behaviors, ideations, attempts, panic attacks, agitation, psychosis. And then these are our most common behavior changes that are physical in nature but appear to be psychiatric. And this again is why I always say, like, I feel like this is such a difficult position to have, where you're trying to kind of like figure out like what's going on when you have all of these medical diagnoses that could present with psychiatric symptoms, such as low blood sugar, hypoxia, head trauma, obviously people taking drugs, things like that, excessive cold or heat, infections of the brain or membrane, seizure disorder, alcohol, drug withdrawal. I always kind of go back to baseline. So, and what period of time did this start happening? So that's where, again, like the assessment piece is so important, because that in itself can really help give clues when you have somebody who's 80 who starts developing hallucinations in like a matter of a day, who has no previous mental health history. You're not going to be like, oh, that's schizophrenia. You're probably going to be looking at one of these. So again, onset of symptoms relatively sudden, any memory loss or impairment. There's a pupils dilated, constricted, unequal, respond differently to light, excessive salivation, incontinence, unusual odors on breath. So again, all signs and symptoms that could present as physical in nature, as psychiatric in nature, but could be underlying physical. So what we use in the field of mental health, behavioral health, is the mental status exam, and you guys do your physical exam. But we're always looking at how are they appearing, how's their speech, are they oriented, Do they have the ability to remember things? Are they aware of where they are, who they are? Is there any bizarre body language, any dystonia, tardive dyskinesia, different movements that are like abnormal that would indicate something going on beyond just like a typical psychiatric presentation? Perception and thought content, psychosis, mood, affect, judgment. So with psychosis, there's different types of hallucinations. Most often, I mean, these like auditory and visual are your most common, specifically if you're talking about people who are schizophrenic or have like bipolar disorder. The other diagnoses are, or the other forms of psychosis are not as common, like the tactile, gustatory, or olfactory. But just something to keep in mind that people do experience those with psychosis. So this was something that I found like forever ago, and I thought was extremely helpful in remembering how to kind of identify some medical diagnoses that could present as psychiatric. So this Mendamine is from the Psychiatric ER Survival Guide. So metabolic, so looking at electrolytes, those types of things, electrical, nutritional, so like deficiencies, drugs and toxins, arterial, mechanical, infection, neoplastic, degenerative, and Creutzfeldt-Jakob disease. So again, lots of different things that present very much like a psychiatric emergency, but is obviously a true medical emergency. So just kind of I'm just going to kind of briefly go over some of the most common psychiatric conditions that you would come in contact with in the field. This again is not the complete list. This is mostly like what we see that would warrant EMS being involved and really just what to be aware of. And I always like to present the fact that it does not need to be precipitated by a major event or a crisis, because sometimes people think like, oh, well, like they were completely fine, and you know, like there doesn't always have to be like, I mean, you could go to somebody who seems to be living a fairly normal, common life, and it's like, why, like they're having a panic attack, and we don't know what's going, why are they experiencing that? Nothing happened that caused that to happen, or and then another thing that I like to always really put attention on is any change or increase in medications. So again, this comes back to the assessment, making sure we're asking those questions. Are you taking medications for anything? And if there's an identification that there is a psychiatric medication involved, has there been a recent change in your dosage? Have you switched medications? Have you stopped taking your medications? Have you been out of them for a period of time? All of those things in themselves can really exacerbate or cause psychiatric symptoms. And then this is the book we use to diagnose. And it's the DSM-5, the American Psychiatric Association for Diagnosing. Again, you don't necessarily need to know this, but just so you know, this is where we get all of the fancy diagnoses. So with the anxiety disorders, I know in EMS, this is something that is seen often. The panic attacks specifically, a lot of times people will think they're having heart attacks, and we understand that. And I'll go over panic in a little bit here, but anxiety is the painful uneasiness, sense of impending doom, agitation, restlessness, often related to things out of one's control. And anybody who's ever experienced anxiety or panic will tell you that a lot of times you feel like you're dying. There's no, like, it's not something that you can just kind of like snap out of. And I think sometimes it's important to be able to explain to the patients what's happening in their body as to why, because, you know, in their mind, they're dying. So then when you're like, okay, like everything checked out, really think you're just having a panic attack, you know, it's important for you to say, you know, when somebody's having a panic attack, they have this rush of adrenaline that's going through their body, like you're going through fight or flight right now, but your body doesn't know that it doesn't need, like, you don't need them. You don't need that part right now. So we could shut that down. Like, you're safe, you're calm. But sometimes, like, that's acknowledging their reality. So they don't feel as if you're kind of just like, it's nothing. It was a panic attack. It's almost could be very invalidating. So I like sometimes to be able, you know, to explain that to them. Here's what's happening in your body. You're flooded with all of these chemicals. And here's, you know, how we can maybe work on getting you to calm down a little bit. So that's panic attacks. I already went over all of that, flooding of epinephrine, how it peaks, builds, and then all of those symptoms kind of come with that. When we talk about phobias, irrational fear often triggered by a specific event, object, and then there's agoraphobia, which is what we hear of a lot with people who are afraid of leaving their homes. It's kind of a big one right now with COVID. I think a lot of people during COVID, their anxiety, panic. I know there has been a significant increase in mental health symptoms and mental health services being utilized as a result of the pandemic. And I feel like agoraphobia is becoming more of a thing than it was before, because now people truly are afraid to leave their homes. There is a real threat. And it's kind of become much more of an issue that I think we're going to be seeing more recently. Bipolar disorder. So 2 types of bipolar disorder. All I'll say is that bipolar 1 is the severe one. Bipolar 2 is the less severe one. Both are obviously have to have a major depressive episode with a manic episode. The patients that you're going to be encountering either in the field or in the ER as a result of their bipolar disorder most likely are experiencing like the manic episode with the bipolar 1 disorder. That's where we see like the psychosis, the people that are up for days on end, not taking care of themselves, drug binges, those types of things. The biggest issue with the bipolar disorder patients is they're often non-compliant with the medications because they make them feel crappy. And when mania is for them feels really good. So when they're at a normal mood, it almost feels as if like that normal mood is really low. So there's oftentimes a lot of non-compliance with medications, and that obviously feeds into the issue. There's also a lot of co-occurring substance use. So it kind of makes it difficult to see like what's causing what. And it can mimic a methamphetamine high. So again, like what's actually happening. And then again, hallucinations, delusions can occur. And so with the mania, again, period of abnormally elevated, expansive, or irritable mood lasting for at least 1 week. So that's going to be like pressured speech, drug and alcohol use, lack of sleep, again, feeling like they're on a high. Unrealistic goal setting, grandiose thinking, just very much like everything's amazing. And then the major depressive episode comes after. And then hypomania is just basically a less severe version of mania, and that only lasts for 4 days versus the week. So again, not like you need to know that necessarily, but just something to be aware of. So when you think of mania, that's the severe, that's typically the one that you're going to be encountering if it's an emergency type situation, but still good to be aware of both. Depression, leading cause of disability, ages 15 through 44. I think we all kind of already know what depression is: helplessness, hopelessness, withdrawal, tearfulness, all of these things. Kids present a little bit differently with like depression and anxiety than adults. And I don't really cover much. I don't think I really cover any pediatric stuff really, but just something to keep in mind, because like with like little kids, sometimes like stomach aches, things like that could be very much so depression, anxiety, not like your textbook here as how adults present. Neurocognitive disorders. So this involves impairment of the neurons in the brain to include memory disorders, personality changes, and impaired reasoning. And I don't know why this slide is very blurry for some reason, but it just shows the difference between like dementia and Alzheimer's, because I know sometimes we use those interchangeably as well. So dementia is a word for a group of symptoms caused by disorders that affect the brain, where the Alzheimer's is the actual progressive disorder that affects the brain's nerve cells, results in loss of memory, thinking, language skills, often results in behavioral changes. I feel like the neurocognitive disorders are very difficult when it comes to, again, being able to truly assess what's going on. So I guess I'll use the example of, I've had a lot of different situations where maybe there's like an elderly person or someone who has already been diagnosed with dementia, or I'm sorry, with like Alzheimer's, or like even just like talking about like dementia symptoms or something along those lines. And they suddenly start experiencing like hallucinations, and it's something that comes on pretty rapidly. So it's not something that like, over time families saying they're starting to do some weird stuff, like they're starting to, accuse me of doing things, or, they're being real suspicious, or they're talking to people that aren't there. Like, it's like more of like a rapid, like this happened, like they're up all night and they're hallucinating. Sometimes it's easy for people to just see that and say, oh, well, they have Alzheimer's. So people with Alzheimer's experience things like that. But again, this is where that assessment piece is important, because it's like, well, is this the normal? Like, is this what they've been experiencing? Have they always had this? Or is this something that just started? And because I have had actually recently examples of people where that has not, like, they have these diagnoses, but then they go into the hospital and they end up identifying there's like a really severe UTI that led to sepsis or things along those lines. So again, really important for that assessment piece. Okay, so just a couple of the examples of what we look at when we talk about neurocognitive disorders like Alzheimer's, Lewy body, vascular, TBI, substance, HIV, Parkinson's, Huntington's, just different examples there. So we're going to go over the agitated delirium, and I'm probably going to ask Larry to jump in when we get to the actual protocol. But so for agitated delirium or excited delirium, neurocognitive disorder and its physiological response is characterized by the following. We see the unusual strength and endurance, high tolerance for pain, agitation, hostility, frenzied and bizarre behavior, hot and diaphoretic skin, unusual speech. Can be associated with drug use, especially cocaine, meth, and other central nervous system stimulants, but it can also be associated with different psychiatric diagnoses. And one of the big things I know, like in the field of EMS and like in police work, there's always the concern of sudden cardiac arrest if a patient fights against the restraints who is experiencing agitated delirium. So the Richmond Agitation Sedation Scale is what you could utilize to identify where a patient is at, and then you kind of go from their score if you're experiencing somebody who's experiencing some form of agitation. So Larry, do you want to jump in and help me with this?
Yeah, of course. So what we decided to do with the behavioral health section is there's a lot of times that EMS providers are, I should have used ketamine on this patient, or I didn't really know if it was appropriate to sedate this patient. So I actually borrowed this. I actually found it in Williamson County, Texas. Dr. Jeff Jarvis was actually talking about this in one of his lecture series, and it actually works pretty well. So what this is it's adopted towards EMS. So essentially what we're going to do is we're going to look at the patient, right? We're going to see that I'm just going to go down the bulleted points here, look at the procedure for RAS assessment. So number one, we're going to observe our patients, okay? Our patient is either going to be alert, restless, agitative, or combative. Then what we're going to do is if they're not alert, then we're going to try to get them to kind of have some sort of stimuli. So maybe we'll say, hey, Kristyn, if she opens her eyes, then that'll get a certain score. Then we'll try to elicit a little bit of pain. So essentially, we want to see the cognitive effect or how alert these patients are. And each one of them will get a score. But now let's jump down to the bottom where we actually have the score, the term, and the description. So I want you to focus right in the center of the chart where it says alert and calm. That'll be a patient like Kristyn sitting right there at the desk. She's alert, she's calm. She doesn't need any stimulus to respond, but she doesn't look very violent or look like she's going to come and attack you. As we go to the positive values upwards, you can see that a patient would get a positive score of +1 if they're restless. So that pretty much says the patient's anxious, but they're not really kind of pounding their fist or trying to act in any sort of aggressive behavior. If the patient is agitated, they're going to get a +2, and that's kind of like patients who are kind of pounding their fist in their hand, or they're pounding, really, pacing back and forth. They kind of make you a little uneasy. And you see in there that it also fights ventilator. That's because this can also be assessed for when we sedate and re-intubate somebody with RSI, or we need to keep them on the vent. That's why it says fights the ventilator there. As the patient increases his or her way up to be more agitated, that's going to get a +3. So these patients might start to take a couple steps towards you, might go and try to charge at you. They're really not combative, but now you're approaching that, you're looking for the closest exit, and you're thinking about getting law enforcement. If you already picked up your microphone and you've asked, hey, I need help. And then the +4 will be combative. And that's where these patients are charging at you. You're in a physical altercation with that patient. So we're going to use this score to say what numerical value does the patient have? And based on that, this is why we went ahead and sedated them. So as we sedate these patients, they're going to go from a positive score, hopefully back down to a 0 where they're calm, but then they can also go to the negative effect. So let's say, for example, we give somebody some Haldol Versed or a combination of some sort of sedative, whatever's in your protocol. They were maybe a +4 or a +3, for example. We've sedated them. Now we're going to reassess them every 5 minutes, and you should see them titrate all the way down to like a -1, which is drowsy, or a -2, which is lightly sedated. And that's kind of where we want to keep them, a little bit of lightly sedated. That's what it means that if I'm using Kristyn as my patient, then I can say, hey, Kristyn, open your eyes, and she opens her eyes. So we've sedated her enough that she's not violent or aggressive anymore, but she's still easily stimulated with a verbal conversation. So we've implemented this into our protocol for 2022, and I think it's going to be really good. And this is also going to help us when we do, or if we do have to take the stand as to why we sedated somebody. We all know the events in the news last year with George Floyd and with other incidents across involving EMS and law enforcement. So this Richmond agitation scale will actually help us as to, document why we did it, how the patient was acting, and then what we did and where the patient was after our effect. So this is the Psychiatric Neurological Behavior Emergency page in the Trumbull Regional Medical Center protocol. So I just want to run you through this, and this should be similar for any agency that you're with. And if it's new, great, feel free to borrow it. But of course, we're going to try to do our universal patient assessment. We're going to try to get that bird's eye view from the door or as we approach that scene. We're going to try, if we're possible, we're going to try to get that patient out of that stressful environment. So that means that if you have a domestic, right, and law enforcement's there and you're able to separate the two parties or even an argument, then you can talk to one patient and figure out what's going on. Maybe they'll calm down. Maybe that stimulus is that other person or that partner. So try to remove that patient from a stressful environment. Then, as Kristyn said, try to identify the cause that's causing this patient to be in this episode. Is it an underlying medical condition or is it acute psychosis? And then we're going to try to obtain that information from our facts, from getting information from bystanders if we can, and talking to the patient. We're going to assess them based on that Richmond agitation scale. And then if we have a +2 to +3, which is agitated to very agitated, then we're going to go ahead and sedate them, all right? So what you have to figure out, if you can find out if they're allergic to, if they have a history of schizophrenia or an allergy to ketamine, then we're not going to give the ketamine. And the reason for that is that patients who have schizophrenia, the research says that giving a sub-dissociative dose, which means a pain dose, right, for ketamine, is more likely to increase and excite the excitatory neurotransmitters in the body and allow those psychiatric symptoms or schizophrenia symptoms to be increased. The good thing is it's only going to last for 90 minutes, but guess what? We're with that patient right now. They're not in the hospital with the extra resources. So let's say that our patient is a +2 or a +3, and let's say they don't meet the criteria for ketamine for whatever reason. So we're going to go over to the left-hand side. So a lot of systems are using haloperidol. We've actually switched to droperidol, but either one, haloperidol and droperidol, those are dopamine receptor blockers. So they act on dopamine receptor D2, and dopamine is necessary for movement. So if we block those receptors, then the patient isn't really able to overcome the receptors and able to enact movement. So we're going to hit them with a combination, 2 separate syringes though, and 2 separate doses. What we're going to do is draw up 5 milligrams of droperidol or haloperidol, and we're also going to draw up 5 milligrams of Versed. The reason we need both of these to work is because the midazolam or Versed is going to be very quick acting. The droperidol or haloperidol can take upwards of 15 minutes to 30 minutes. So the Versed is going to get on first. It's going to cause sedative effects. When that starts to wear off, then we're going to hit them with the dopaminergic, anti-dopaminergic drug, haloperidol or droperidol. Now, if after 10 minutes, the patient is still kind of restless, then we're going to repeat the anti-dopaminergic. We're not going to repeat the midazolam or the Versed because that's going to have respiratory depression, and that's not what we want. If the Versed isn't working on 5 milligrams that you're giving intramuscularly, then we need to hit them with some more anti-dopaminergic. And because these drugs, Haldol and droperidol, are fat soluble, we want to get a little bit more in so that they can stay in the body. So after we do that, we have to 100% monitor their airway, monitor their capnography. So all these patients will get end-tidal CO2 via nasal cannula. We're going to maintain their oxygenation to about 94%. And then here's what's critical. You absolutely need to be ready with your airway kit, because these patients who are sedated, they have the tendency to lose their airway or maybe need a little bit of assist. So when you do this, this is much safer. Doing a chemical restraint is much safer than trying to physically restrain somebody in the back of an ambulance or just, because what happens is we might have a law enforcement on the scene, but as soon as they get to the hospital, they have to cut those restraints, remove those restraints, and then that patient's combative to the nurse. And I watched it happen at St. E's. The patient was tied down, they cut the restraints, and then the patient punched the nurse in the face. So we prefer chemical sedation over physical restraints. So after all that, you're going to do your normal thing. And then Kristyn's going to hit on extrapyramidal side effects. But those are side effects that are caused by the anti-dopaminergics like the droperidol and the haloperidol. And those are just repetitive muscle movements. And if they have those, like lip smacking or tartar dyskinesia or Stedham's chorea, which is just, slithering of the arm, again, she's going to hit on that. But we're going to give them some Benadryl. And that Benadryl is going to stop, hopefully, those extrapyramidal side effects. I want to make sure that you guys understand that Benadryl is not very good for sedation for adults. Not only does it have the antihistamine effect, it also blocks alpha. So if you start to give this to somebody who is upper on age, then you can actually block alpha, and alpha controls the blood pressure. So you're going to decrease their blood pressure. So Benadryl should not be used for sedation. It should only be used for the extrapyramidal side effects. So again, assess your patient, give them a RASS score. If they're not a candidate for ketamine, give your Haldol in one syringe, inject them in one deltoid, give the Versed in the other syringe, inject them in the other deltoid or the hip, and reassess it. And then reassess that RASS scale every 5 minutes. If for some reason you need to give the ketamine, then ketamine, the standard dose for sedation, is usually right around 1 milligram per kilogram. And again, make sure that you're monitoring their airway, you're doing their capnography, you're watching their breathing patterns. And what the EMTs and paramedics didn't do for those cases that got national news is they didn't monitor their airway, the patient's airway. They didn't have them on capnography. So they weren't able to realize the patient went into respiratory depression and then ultimately into cardiac arrest. So use your head, use the tools that you're given, and the patient will do quite all right. So moving forward, excited delirium is really something that's caused by different factors. And so we want to address the patient. We want to figure out what's going on. There's a video out there, and I'm sure many of you have saw it, of this guy, punching through a fence. Or in Florida on the turnpike, there was a guy, they thought zombies came to life. There's a guy on the Florida turnpike and traffic was stopped and he was trying to bite people's faces. There's also a clip on YouTube of somebody yelling obscene gestures, and literally 50 people come and jump on top of them and they smash them into a reeds and restrain them. So excited delirium is those violent combative patients who have a RASS score of +4. And the mnemonic in here is not a crime. And the reason is because this is going to help you distinguish excited delirium from any other psychosis. Excited delirium is a life-threatening emergency because these patients, if they don't get sedated, they're probably going to be shot and killed by the police, or they're going to cause physical harm on somebody else. So with not a crime, N is for naked. So they're hot. Their body core temperature is hot. And if we were able to measure that before we had to sedate that patient, it'd be upwards of 103, 105. And they'd be super hot. So that's why they strip or they're naked. The O is for object, which means they're violence against something. They're usually, you know, busting up things, taking chairs, just hitting inanimate objects. They're very tough. That's what the T's for. People like superhuman strength. That's what it's called. It's acute. It happens very abruptly. They're usually confused. They're resistant to commands. You can ask them to sit down or come over here, have a seat, and they're not listening to you. They're going to have very incoherent speech. They sometimes have a history of mental health, but they're definitely going to make you uneasy, right? And so the other thing is to request early backup. And if you got to just watch this patient from several, you know, yards away and just drive behind them as they walk down the street, until you get the rest of the people there that you need law enforcement, extra crews, don't approach this patient. But when you do have the resources that you need, you're going to you're going to address this patient very, very diligently. So what we're going to do, we're going to draw up 5 milligrams per kilogram of ketamine. Some people will just draw up 500 milligrams. Some protocols say 200 to 250, but the appropriate dose based on the literature says 5 milligrams per kilogram of ketamine. And that's enough to knock down a horse. So we're going to draw it all up. And how we have it in our boxes here at Trumbull, at least, is that we have 100 milligrams and 500 milligrams and 5 ml. So we're going to draw up all 500, for example. We're going to take it and we're going to do the sneak attack if we can. We're going to inject it into the lateral thigh. We're going to take the syringe and the needle and toss it the opposite direction, and we're going to get the heck out of there. This patient is going to continue to go about their business until the ketamine hits them, and it will hit them in a couple of minutes. When it hits them, they're going to start to get a little drowsy. They're going to walk, and they'll really just pass over. When that happens, that's all right. Put a C-collar on them, flip them onto a sheet, put them onto to the cot, elevate the head to about 30 degrees, and get about your way. These patients, because we hit them with so much ketamine, we hit them at the anesthetizing dose. So we will have to probably intervene with their airway. But again, that's better than the patient being shot or, you know, the patient physically attacking you or causing harm to somebody else. So again, monitor their capnography, give them some oxygen, and have all your airway equipment open. So whether that means I have the intubation kit, I had the King airway, or my rescue airway, and I have my BVM already, all of that needs to be out and open. You do that, you figure out what's going on with the patient, you monitor them, you take them to the hospital. Again, do your normal vital signs, obtain that 12 lead, get that IV now that that patient's sedated, draw some labs if you can, because they also want to see in the hospital if there's any sort of substance on board. And then the number one thing that I think we forget to do is give them some fluid. When these patients start to come around, they're going to start to kind of be, one, they're already dehydrated from being so violent and the body core temperature being up and being so inactive, but also they have like a hangover effect. So we want to just give them some fluid to make sure that, you know, we're doing the appropriate rehydration for them. But those are three of the big things that's with us and that's up and coming. And, you know, there are stories out there about excited delirium. If you just go onto YouTube and you search excited delirium and EMS, you'll see what these people have done. And this is the safest way to get these patients sedated and get them on and get them that psychiatric help that they need.
That was probably explained way better than I would have ever explained that. So thanks for jumping in and doing that, Larry. So the kind of moving on to schizophrenia spectrum and other psychotic disorders. I don't know.
You're back now. I think you lost your.
Am I back? Somebody was
we
like,
see you. You just got to open up your presentation.
PowerPoint. Let's see.
oh,
Okay.
but can you see it now?
It's loading here. Yep, we got it.
All right, perfect. Okay. So chronic with no return to premorbid level of functioning. There's multiple types of schizophrenia. You have like your paranoid schizophrenic, which is the one that people are most commonly know of the most. Debilitating, they experience debilitating distortions of speech and thought, bizarre delusions, hallucinations, social withdrawal, catatonic behavior, lack of emotional expressiveness. One of the biggest things to kind of keep an eye on is specifically related to like younger adults, because that's usually when people start experience or will experience their first psychotic break. A lot of times it could be triggered by like a stressful situation. We see it a lot in people in like their first couple years of college. So they'll experience what we call the prodrome, where they're in that period of like they're starting to get like maybe some like awkward behaviors and things that families like they're isolating, they're kind of doing bizarre things, but it's not enough to say like, okay, they're full blown experiencing a psychotic break. And then sometimes it takes just like one stressful life event or something that just triggers that full psychotic break to come on. So we used to see this a lot, like I said, in, people maybe starting college for the first time. So men usually will develop it at a younger age than females, and it's obviously a lot of times more common in men too. So just something to keep in mind if you're ever dealing with somebody who's like in that young adult period of time, and families like, they seem like over the past couple months they've been kind of acting different, and then all of a sudden, like over the past like few weeks, we've really noticed these major changes, and that could really be an indication of like a schizophrenia or like that first psychotic episode developing. So again, there's the paranoia, so exaggerated, unwarranted mistrust or suspiciousness of others. Delusions, oftentimes people will think that, people are out to get them, or their neighbors are doing things to them, like bizarre. I'm sure you guys have all experienced calls where it's kind of like, where did like that they even come up with this thing? So they could be very bizarre. And then sometimes they can have obviously the aggressive behavior as well. So what is psychosis? I know we kind of went over this briefly already, but patients out of touch with reality, they're experiencing hallucinations, or they may be experiencing delusions. They can last for only a short period of time, or they can occur as chronic. I would have patients who would only experience psychosis when they were under immense stress or when they would stop taking their medicine. And then I had patients who, no matter what amount of antipsychotic they were taking, they always had some psychosis, but it was enough that it wasn't affecting their ability to function. So just because somebody experiences psychosis all the time doesn't necessarily mean that they're requiring psychiatric hospitalization. It becomes an issue when it's impacting their day-to-day functioning, or obviously like the hallucinations or the psychosis is command in nature, or it's causing them to have like threats towards themselves, somebody else, things like that. Okay. So again, it can be very difficult to differentiate primary from secondary psychosis, specifically for EMS. So primary psychosis is going to be the true mental disorder connected to something such as schizophrenia or another psychotic disorder, where secondary psychosis is going to be a temporary condition resulting from another traumatic or medical issue. So this again is where I bring in the example of the elderly with UTIs that have psychosis, and then it clears up and we're not experiencing that anymore. So that would be secondary psychosis, or even induced by drugs or something along those lines. So I've already used that example about an elderly individual presenting, because again, it's unlikely that an elderly person is going to develop schizophrenia, or even like looking at some of like, some like head trauma or other things that, if you have somebody who's like in their 50s, even, it's not typical that somebody in their 50s is just going to become psychotic. Could it happen? Probably. There's people out there that does happen to, but we know in the research that it's typically young adulthood is where people experience their first psychotic break. So what could be causing this? We need to always be really digging for that. And it's your job to obtain as much information as possible to assist in determining whether this could potentially be primary or secondary. For substance use and addictive disorders, there's a high level of comorbidity, which often results in a drug and alcohol screen to rule out the primary cause of a psychiatric presentation. So it's very difficult because we know that one of the things with mental health diagnoses is people do use drugs and alcohol as a means to cope or lessen their symptoms. So sometimes we have so many things happening at the same time. It's hard to really identify what's causing what until we get that drug and alcohol screen and say, okay, now we see that we have this on board. So this could be affecting, this could be explaining this presentation versus just saying like it's related to an underlying psychiatric diagnosis. So I'm sure there's a bunch more. I know there's different like street names for a lot of like drugs that are out there currently that I'm probably not most up to date on. But obviously most common symptoms that are most common substances that we're seeing that people will abuse that can cause issues. And another thing too, even with like cannabis or like K2 or even like acid. So sometimes we'll see that somebody utilizing or trying that for the first time could also bring out that psychosis. So it's not that the drug itself caused them to become psychotic or have a psychotic disorder. They were probably always going to become like schizophrenic or have psychosis, but the drug just helped bring it out sooner. So sometimes that's also that because when I worked in adolescent psych, with 12 to 17-year-olds, we unfortunately would see people who would go into that prodrome of schizophrenia much earlier because they tried like the synthetic marijuana for the first time, and it just like kicked that psychosis out really far. But again, it's going to take some time to really figure out if that's really what's causing it, but still something important to keep in mind. So this is a term that we used to use in the emergency department for patients who would present as under the influence of alcohol, altered mental status as a result of being intoxicated, and reporting suicidal thoughts. And we would say that because oftentimes once they were sober and we were able to do an actual good, thorough assessment, sometimes they would have zero recollection of even reporting those things. So I always make sure, though, to really stress that when somebody's under the influence, a patient is experiencing altered mental status, so they're incompetent in that moment to really make any sound decisions regarding their treatment. So it can't just be blown off as like, oh, well, they're trashed and they're saying they're going to kill themselves, but they're drunk, because it's like you are they even really able to say that for themselves or make those decisions? So we always used to say like, we weren't even allowed to go in and do our social work assessment on the patients until they were at that legal limit to where we can actually go in there and assess them. So trauma, stressor related. So this is like when we think of things like post-traumatic stress disorder. So you think of like military population, hyperarousal, vivid recall of experiences. This could be very difficult to identify as well, because a lot of PTSD symptoms also mimic other diagnoses like mania. Because if you may have somebody who just came back from combat and they don't sleep, they're not sleeping, because that's a very common symptom of PTSD. So somebody may think, well, they're manic. Like, why are they not sleeping? Or they're like super hyper aroused and things like that. So sometimes PTSD can kind of present as that way. And also psychosis can also be present in PTSD, which is another thing too. So again, not necessarily your role to truly like figure out like, what is this diagnosis? I'm going to go in and tell the ER doctor, I think it might be, but it is important for you to, to have these things to be aware of, that they could present these ways. And then ACEs is the Adverse Childhood Experience Scale. So that's basically just the screening tool that we use a lot of times in mental health to identify that if somebody has experienced adverse childhood events, it really could cause them to develop PTSD and other mental health issues. So again, when you're working with children or things like that, also something to really kind of keep in mind. And this is just another thing that I like to show, because a lot of times I know when we talk about mental health and psychiatric, we tend to think that a lot of it is just like stuff that we like, these symptoms that we've identified and said these are the diagnoses, but there are now coming out with a lot more physical evidence of things. So like you can see here on the left is a healthy brain, and on the right is a brain that had been through some form of abuse. So there are neurological and biochemical changes that occur as a result of trauma in general. And we're now connecting a lot of that to physical health issues. So that's where you may see like a lot of people that have a lot of physical health issues. A lot of times you may be able to identify there's an extensive trauma history. And why is that important? Because there's contraindications when it comes to trauma. Things like physical touch, hyperarousal, hypervigilance. If you're requiring a physical hands-on assessment, you know, use extensive verbal cues, ask for permission, because these people could easily be re-triggered, and you obviously want to make sure that you are using empathy and approaching that. So I'm going to kind of just run through some of these, not really go too in depth with extrapyramidal symptoms. So caused by dopamine blockade or depletion in the brain. So lack of dopamine often mimics idiopathic pathologies and often develops as a result of taking different psychiatric medications. So like in the example that like when Larry was showing the protocol there, so that's, you're giving them something like Haldol. So we in the field of like behavioral health are patients who are taking things like Haldol regularly, which they're not often because that's very, it's an old medication, but we do still use it for people who have resistant, who are resistant to other medications. A lot of times they're prescribing them something on the side to help prevent this from happening. But that's not always the case. And these are things that you still should be aware of. Things like neuroleptic malignant syndrome. This is severe, life-threatening, again, associated with antipsychotics or other dopamine antagonist use, and typically presents within 72 hours of exposure, but it can develop up to 1 week. So we look for things like extreme elevation in temperature. All of those symptoms are super important to kind of keep an eye out for. And again, it goes back to the assessment. Did you recently start taking a new medication? Has there been a recent increase in a medication? It's really important to get that information to help you determine that. Medication-induced acute dystonia, so typically develops within a few days of raising the dosage of or starting a medication used to treat EPS, such as a neuroleptic. So you can see this guy here is experiencing that. And you see the abnormal contraction of the head, the neck, limbs, trunk, things like that. Super uncomfortable for patients when they are experiencing that. Medication-induced acute akathisia. So symptoms typically develop within a few weeks of initiating, increasing, or decreasing the dose of an extrapyramidal targeting medication. Complaints of restlessness, fidgety movements, rocking, pacing, inability to sit still or stand still. So a lot of times people who are taking medication for like bipolar, like I said, schizophrenia, may notice like that, just like, it's like they almost say like they feel like they're like kind of crawling out of their skin. And again, it's important because one thing that I have learned is not all doctors are aware of what other doctors are prescribing. So I've seen lots of situations. So like if somebody's just seeing a psychiatrist, we know that most often the psychiatrist is aware of these things and may already be prescribing something on this side, like a cogentin to prevent like the EPS related to like a Haldol or something like that. But we now have situations where somebody's seeing a psychiatrist, but then their primary care is also giving them medications and don't even know that they're seeing a psychiatrist, or they went to the ER and the ER doctor gave them something. So again, that's why it's really important to kind of be aware of that. Tardive dyskinesia. So that's those involuntary movements of the tongue, jaw, trunk, or extremities. Typically last a few weeks in relation to a neuroleptic that has been taken for at least a few months. There's neuroleptic withdrawal dyskinesia, which mimics tardive dyskinesia, but it's the result of a discontinuation of a reduction in the dose of a neuroleptic. So these are just as a little graph to see the different symptoms. So like the movements, rapid body movements, blinking, difficulty breathing, difficulty swallowing, difficulty speaking. And then there's the medication-induced postural tremor. So again, postural tremor often associated with use of medications such as lithium, valproic acid, or antidepressants, similar to a tremor from anxiety or stimulants. So something, again, keep an eye on if there's any of those medications that are being reported to be taken. Antidepressant discontinuation syndrome. So this is what can develop if somebody abruptly stops taking an SSRI and SNRI for at least 1 month. They often begin developing these symptoms within 2 to 4 days. It kind of it depends on the medication. Obviously, some of the SSRIs and SNRIs have a much longer half-life than other ones. But if somebody's experiencing this, they may say that they see flashes of light, electric shock sensations, nausea, hypersensitivity to noise and lights, anxiety, feelings of dread, things like that. So we all know about the people who are like, oh, I just ran out of my medicine. I just never got a refill. And then, you know, they may be experiencing some of those symptoms. It's more of a discomfort. And then there's serotonin syndrome, which is if somebody has high levels of serotonin in their body, often from starting a new medication. And this is, again, where I talk about doctors maybe prescribing things from this person and this other doctor's giving something, because combining a migraine medication with an SSRI or an SNRI could cause serotonin syndrome. Obviously, illicit drug use, anything that's going to cause an increase in serotonin, and it could be fatal if not treated. So again, those are some of the symptoms of that there. And then these are just some of your common psychiatric medications. I put all brand names on here, which most people use generic, so anyway, so there's your antidepressants, your antipsychotics, your first generation, which is like your Thorazine and Haldol, and then your second gen, and then your mood stabilizers, which is what we use for bipolar disorder, and then your anti-anxieties, such as the benzodiazepines, Xanax, Klonopin, Valium, Ativan, and then stimulants that we use for ADHD. Larry already did that. So we're at an hour, so we could take a break.
Take 10 minutes,
I'm
5 minutes.
How long do you want to take a break for?
Kristyn, that'll be up to you. If you know that you're going to finish on time at 8 o'clock, so it's up to you. We'll give you 5 minutes, 7 minutes, something like that.
Yeah, I feel like I should be good to finish because I just have my next presentation. So
7:10.
maybe like 7:10.
Okay, we'll do 7:10. Everybody on their way out, please go ahead and raise your hand. We'll take attendance. If you have any questions, put them in the chat box, and we'll see you back here at 7:10.
You want to go to the next presentation?
Yeah.
13-minute break? That's crazy. That's crazy.
You're taking coffee.
I have a punch press. I don't have a real coffee maker. Because when I got my coffee maker, it was my ex.
Have a French press.
I do.
Most people already know, but as usual, please put your hands up so we can take attendance. Much appreciated.
I'm going to check.
Here's somebody say a 13-minute break. That's crazy. Oh.
Wait, open up.
Matt won't get everybody started.
All right, everybody, we're going to get started here again in a minute. I'd appreciate it if you take your hands down now. Thank you, thank you. Here's part 2 of Kristyn Woodward.
All right, so for this part, we're going to go over suicide assessment and prevention efforts. Obviously, this is a very hot topic right now. There's been a significant increase in suicide deaths and suicide calls, specifically over the pandemic period of time as well. So hopefully this will be helpful. Try to figure out how to change this. Okay. So just some basic statistics, and these are from 2021, but suicide rates increased 33% between 99 and 2019. There was actually a small decline in 2019. 47,500 suicide deaths in 2019 alone, which would equate to 1 death every 11 minutes. We know that suicide is the 10th leading cause of death and is one of just 3 leading causes that are continuing to be on the rise. We know that males are more likely to die by suicide, where females are much more likely to attempt by 3 times. So this is a little chart to kind of show the different methods that people will utilize and like the lethality associated with that. So this is you can see with like firearms, suffocation and hanging, poisoning, overdose, cutting. It kind of goes through that there. So when we're talking about suicidality, we talk about lethality and means. So lethality means, well, lethality is how lethal is the method that they're using in an attempt to kill themselves, and then means is that method. So in suicide assessment, we focus heavily on lethality and means. Is this method that they're choosing have a high level of lethality, such as like a firearm? And you can see here on this chart where like firearms, number of deaths, lethality, irreversibility, accessibility, acceptability, all the way through, very high. Versus if you look at cutting, lower number of deaths from cutting, lethality is lower, irreversibility is lower, but obviously it's much more accessible because you can cut yourself with anything. So again, we look at these things and we take these into consideration when we're doing suicide assessments, because if somebody's saying, I have a bunch of guns at home, then that's going to put their lethality rate much higher because they have access to lethal means. So for an acute suicidal crisis, that's going to be where, again, EMS is going to be involved. 48% of attempts actually began within 10 minutes of the person thinking about it. So I think that was something that, over time, that's a little bit weird, because I think we're used to always hearing about the person who's been thinking about suicide, forever. Like there are people that do have suicidal thoughts that, are kind of there in the background, all the time. But then we're finding though that a large majority, or 48% of people who have actually attempted it had happened within 10 minutes of them thinking about it. So it's often precipitated by some type of event. So I'll talk a little bit more about that in a minute. And then we find that 90% actually never attempt again. So that's again why it's important. Like if we could jump in here and prevent this, or be a part of helping to decrease this, then that could obviously be very, very good. 4 most common methods: self-inflicted gunshot wound, hanging, poisoning by ingestion, or carbon monoxide poisoning. So when it comes to suicide, every threat, attempt, gesture, or verbalization should be taken seriously and further assessed. we find from research that most people don't want to die. A lot of times when people will wake up from a suicide attempt, or they're like, I'm actually really glad that I survived. It was just something in the moment. And we talk about things like self-injury, such as like cutting. So the research shows it's not often suicidal in nature, but it requires further assessing to determine if there are suicidal ideations present or if the patient requires further assessment. And I always use the example of that's not a normal way to deal with things. Obviously, we all have ways that we deal with anxiety or stress or things like that. But if somebody's turning to cutting themselves as a way to deal, then that's obviously indicating that there's still something going on that probably needs to be addressed. And maybe that won't necessarily mean being addressed in a psychiatric hospital, but at least starting that conversation. And again, you can't just blow it off as attention seeking, because it takes that one person where you're like, oh my gosh, we're going to this guy's house again. How many times are you gonna threaten these things, but you haven't actually ever really attempted suicide? That's not our place to, it's like we have to say, okay, this is what they're reporting. This is their level of risk as a result. We need to get this person to be assessed further. We know that research shows that asking about it does not increase risk. So this is something people are like real weird about asking about suicide. I'm sure you all have experienced in the ER. If you've ever witnessed like the people in triage in the ER when they ask the suicide questions, and it makes you feel uncomfortable because they're like, any thoughts of suicide or any thoughts of killing yourself or anyone else? Like, it's so quick and like no eye contact. Like, I just want to get this question out as fast as I can because it makes me so uncomfortable. If somebody is actually having those thoughts, do you think that they would be like, yeah, I actually have been having? No, they're going to be like, okay, like clearly you don't care if I'm having those thoughts or not. So again, that compassionate questioning is super important. And another big piece I always say is you can't just rely on disclosure of suicidal thoughts, behaviors, and plans. You have to look at the whole picture. So in the same way that you would with a medical emergency, you're not just going to say like, well, I mean, he doesn't have a huge wound on his body, so probably okay. Like what else is going on? Like, well, we just found out that they're going through a divorce, or they're using, but you got to kind of take all of those factors together. And that's ultimately what makes us helps in making decisions of whether or not somebody's at high risk or not. And again, it can emerge rapidly. Often attempts are unplanned. People get dumped. There's a significant trauma or crisis that occurs in their lives. And it's in that moment of impulsivity where oftentimes we find that people, so that's where we talk about like lethal means restriction. If we can help prevent people from having access to those things that they could, turn to in those moments, then that lowers their risk of suicide. So that's why it's also very important to ask patients if they own or have access to firearms or other lethal means. Because if it's like, like I've been having thoughts of, I sometimes like I wish I wasn't alive, but I don't really actually want to hurt myself. I have no desire to hurt myself. But they're like, yeah, I have firearms and things like that. Sometimes it's, it's important to know, and then being able to tell them like, okay, maybe we should have so-and-so take that. And those are like some of the things that we do in the ER with patients to make sure that they're safe. I know, again, that's not necessarily something that you would be doing, but still something to just be aware of how we try to help prevent some of that. So we look at attempters versus ideators. So attempters most often are unemployed males, 40 to 44 years old. This is just what statistics show. A lot of times physically ill, have health issues. Sometimes there's relationship issues, social isolation, hopelessness. Very common in the people that we see with attempts. Ideators motivated by anger or some immediate life situation. So again, the ideators are the people that are just often thinking about it, but not really wanting to or planning to attempt. It's just kind of something that's there. So in primary care, or in general, I have primary care in here for, I think, a previous presentation, but often like a primary care physician or EMS will check your temperature, your pulse, your respiration rate, blood pressure as a standard part of an office visit. We have started to try to push identifying suicidal or homicidal or just like mental health crises in general as the fifth vital sign. So you think of like a suicide assessment as that, and then we use certain measurement tools to assist in identifying if there's an underlying mental health issue in the same way that we would if there was elevated body temperature that would then raise concern of an infection. So I'm not sure if there are certain scales or things within the field that you guys utilize to kind of ask those questions. But there's like the Columbia Suicide and Severity Rating Scale is one that is most common, and anybody can use that. And I'm going to link that in here too, just as something to kind of help, even just to go through like the specific questions to ask during a suicide assessment and things like that. So although it's uncomfortable, the biggest thing is to be direct and very specific in your questioning, and implement an expression of care. So again, showing hesitation, apologizing, resistance to asking shows less efficacy and honesty from a patient, obviously, because then they're going to feel shameful. They're going to feel like, oh, like if you're afraid to ask me about this, I don't really want to tell you about it. So are you having any suicidal thoughts? And the expression of care piece comes in sometimes because let's say that when you get there, you find out that they just went through a breakup. So expression of care is kind of putting in a statement to then lead you into that question so it doesn't feel so robotic. So instead of just saying, are you having any thoughts to kill yourself? You may say, you know, sometimes when people are going through a breakup, they may begin experiencing, you know, thoughts of suicide. Are you currently experiencing any thoughts of wanting to hurt yourself? So that can kind of be an example of using that so it doesn't feel so robotic, but you're also, you know, kind of tying in something to help kind of be empathetic towards them. So again, that's kind of an example of what I used here. So are you having any thoughts of killing yourself? Do you have a plan, or have you been planning to end your life? If so, how would you do it? Do you have access? Okay, so do we have the drugs? Do you have a gun that you would use? Where is it right now? All of these things are going to indicate the risk level. And then how likely do you think you are to actually carry out your plan? So like what stops you from killing yourself? So that's where we're going to identify if somebody actually has intent. But again, like it could be very complicated because you may have somebody who's saying like, yeah, I do have thoughts to kill myself. I do want to die. I have an entire bottle of Tylenol that I've been keeping next to my bed for when that moment comes that I decide but right now I don't want to do it now. So I'm good. Like, but you're still seeing somebody who's expressing active suicidal thought, has a plan, maybe doesn't have intent right now in this moment, but that's pretty high risk. So again, this could be very like touchy when it comes to some of these things. So another thing I put in here that I think that kind of goes with the way that you lead it is just that compassionate questioning. So be nosy. So you would not have any problem being like, so do you have high blood pressure? Like, how long have you been on medication for that? So you have to get just as thorough of assessment with these things. It's not being nosy when it comes to somebody's mental health and preventing a psychiatric emergency from occurring. So, you know, do you go to counseling? Do you have a psychiatrist that you see? How long have you struggled with depression or anxiety? Those are all, you know, really important questions. Have you ever attempted suicide before? That's a huge lethal, or that really raises somebody's lethality if there's been a previous suicide attempt. And, you know, those are all really important things. And I know there's so many things that you have to keep in mind when you're assessing for everything in general, but with suicide specifically, I think that, you know, really being as thorough as possible in identifying past, current, like, is this a new thing? Has this happened before? Have you been hospitalized before? You know, are you on medication now? Just really trying to get those details, because there's oftentimes too where I would call EMS as like a therapist, and I would provide all of this information to EMS as far as like, this is, this patient was in my office, they reported suicidal thoughts, this is the plan, blah, 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 blah. And then I would have like our nurse call the hospital to do nurse to nurse or whatever. And like somewhere in translation, like it was just like, oh, well, they were just brought by because they were at their primary care office and they were suicidal or something. And I know that oftentimes like things can get lost, or like even it's the facility that you're sending them to or whatever, but some of those details could be super important because it could be a difference between whether or not this facility is just like, oh, okay, well, they're saying they're fine, like they're good to go, versus maybe some of the things that were shared with the people that sent them, and then with EMS, with you guys, and you can really help, further assist them in getting the care that they need. So this was that screening tool I was talking about, and you guys can go to that. It's cssrs.columbia.edu. We use this to kind of identify suicidal risk. So have you wished you were dead or wished you could go to sleep and not wake up? Have you actually had any thoughts of killing yourself? Have you been thinking about how you might kill yourself? Have you had these thoughts and had some intention of acting on them? Have you started to work out or worked out the details of how to kill yourself? Do you intend to carry out this plan? Have you ever done anything, started to do anything, or prepared to do anything to end your life? So again, like this is like universal, like I think all over the country. There's different like schools, healthcare systems that have implemented the CSSRS kind of as just like a screening tool. And it's actually like a drop down thing. I think there's like, I don't know if there's an app that you can even use on your phone where like if you're negative for like, so if you're positive for like the first one, but then you're negative for the second one, and then the third one, it kind of stops. But like if you have positives, it kind of is like a trickle down effect. So it almost like leads you to see, okay, based off of this, it's going to continue to go into more questions. So clearly this person is super high risk. And then obviously if they're yes to all of them, then this person is extremely high risk. So Larry or Matt, do you guys have any like screening tools or anything like that that you use specifically for like suicide assessments?
You know what? Not particularly, I don't think. I guess we should. I mean, we try to quantify everything else, right?
I mean, I was just curious. I didn't know. And honestly, like that's not even something because I know we're just so used to just like kind of asking. But yeah, I mean, could be helpful in those situations to help identify like, I guess like how in again, it could be used by so many different so you don't have to be, you have to be trained in the screening, but you don't have to be like a mental health professional. Like you can be a medical assistant, you could be a secretary, and all it's going to do is give you like what their risk level is. But even if somebody is low risk based off of a screening tool, you're still going to use your clinical judgment and collection of other things. But it could still be good, I guess, to maybe even just kind of bring all those things together, make it quantifiable.
Hey, Kristyn, I think Sad Persons is one that is preloaded into most of our EPCR software. And Sad Persons is really good to identify risk too. And I think at the end of it, when you're done, I'll share my screen from our version of Health EMS through Stryker, and right under the Psychiatric tab, it has Sad Persons. And I know when I went to medical school, that's one of the things that they taught us to do is to, when you're doing your initial patient interview, when they come in, before you're referring them to mental health, is just do a quick Sad Persons questionnaire to see if they have high risk, and then you can refer them elsewhere. But when at the end of your presentation, let me know, and I'll bring this up.
Okay. All right. So again, our goal is always in psychiatry is always least restrictive. So how can we ensure that this patient is safe, but in the least restrictive manner? So different levels of care in the same way, like in the medical field and psychiatric emergencies, our lowest level of care would be something like outpatient. So this is like your traditional counseling or psychiatry at a community health center. A higher step from that is going to be something like intensive outpatient or a partial hospitalization program. So that's where people would actually go multiple days a week to a program, and they would do like intense group therapy, individual psychiatry. So it's higher up from, so a lot of times, sometimes when you will send somebody to the emergency department and maybe they're on the fence, they're, and like the social worker assesses them and they end up determining, this patient isn't somebody who necessarily meets criteria for inpatient admission. A lot of times they're going to refer them to something like intensive outpatient, because obviously like they were severe enough, or there's a lot going on that they felt that they needed a higher level of care than just seeing a therapist once every few weeks, or maybe that's not working for them anymore. So there are other steps beyond just community and psychiatric hospitalization. So there's also crisis centers in some locations where people can go as like a voluntary admission for like a quick period of time just to get stabilized on medications and things like that. Emergency department, obviously that's where we would send people for the actual assessment, medical clearance piece. They are, I know in some places, and I know around here that's not a thing, but I know in like South Carolina, other states are trying to work on like almost like a telemodel for this, to where like if somebody comes into the emergency department and like they need, maybe it's just like a psychiatric medication change or something where, like they don't necessarily need to be admitted psychiatrically, we can get psychiatry to come on telehealth or something along those lines, or have psychiatry be in the emergency department as a member of the team in the same way that we would consult cardiology or other professions to come in. So, and then obviously highest level of care is going to be inpatient hospitalization. So I already kind of went over what would qualify somebody to require an emergency intervention in relation to like psychiatric. So suicidal, homicidal, decompensated psychosis, manic behavior, not tending to activities of daily living or basic or physical needs due to their mental illness. So I think I understand that there may be people here that aren't from Ohio. So when I go over the application for emergency admission, obviously this is just related to Ohio. I know other states have different rules that they use as far as for psychiatric admissions and things like that. I'm not going to go super in depth because you guys aren't the ones that are completing it, but just to be aware of. So this is that pink slip that we always refer to, the legal process that's used during a behavioral health emergency, that basically will say that somebody who's is experiencing a psychiatric emergency, we can say that they're required to, be transported to be further assessed by psychiatry and things along those lines. So when we look at psychiatric admissions, there's either voluntary or involuntary. So your involuntary is when we talk about the pink slip. So, obviously, in those situations where you have somebody who is like kind of on the fence, or, there's suicidal, homicidal ideations present, and they're not like, I want to go, like I'm willing to go. That's obviously when law enforcement gets involved. And then I always pressed here that suicide and homicide are not the only criteria for a pink slip. There's actually, other boxes on there that indicate things such as like, due to this person's mental illness, it is evident that they're, not able to take care of themselves, or they're a threat, or something in those wording. So that could be where like the mania piece comes in, because sometimes you have some people, and I know that there's a lot of times maybe some struggle between like EMS and police, because EMS isn't the one that's doing the pink slip. So sometimes to just have that education and be able to say like, okay, like, no, they're not suicidal, but they haven't slept for 2 weeks and they're clearly psychotic. Like that's a problem, clearly, so, what happens when a patient is sent to the ER on a pink slip? So again, going back to the pink slip. So these are the people that can complete it. So a psychiatrist, a licensed physician, a licensed clinical psychologist, a clinical nurse specialist or certified nurse practitioner who is certified as a psychiatric mental health CNS by the ANCC. So not just like any nurse practitioner, you have to have that special certification in Ohio, or a health officer, parole officer, police officer, or sheriff. When we get them on scene, we say, we have this patient here, they're expressing suicidal thoughts. They decide that, in order for them to be safely transported and, to ensure that they're safe, let's say police initiates the pink slip. So then they're taken to the emergency department for further evaluation and medical clearance. They're often seen by the physician. ER social worker will do their assessment as well. And this is, again, why I stress so much how important your assessment is, because you're that first piece of information to really give to people in the ER of like, this is what's going on, because we can't just always go by what the patient's reporting and what, a lot of it too is like, what was reported to you? What did you see on scene? Did it look like it was safe? Or did you have red flags? Were there concerns that you had? All of those things really should be taken into consideration by whoever's assessing them in the emergency department as well. So the physician, once they're in the emergency department on a pink slip, if the physician doesn't feel like, after like they have a period of time where they've done their own assessment, their own medical workup, they do have the ability to rescind the pink slip. So I feel like sometimes there's like I don't know if there's like confusion about that, where people will think that like if a police officer pink slips you to go to the hospital, that automatically means you're going to be there for 72 hours. But it's more so to get them there to get assessed. Because sometimes I feel like I've heard people even make that like almost like threatening towards patients. Like, if you either do this the easy way or the hard way, you want to be there for 72 hours or you want to go on your own. So it's kind of can be difficult, but just understanding that. And according to the law, they have to be examined within 24 hours of arrival. And they're discharged once they no longer meet criteria. So within 3 court days, so this is where the 72-hour hold comes in. If somebody is admitted for 70 and they're on that 72-hour hold, they either have to be discharged, they have to agree to continue their admission, or that's where the staff in the psych hospital would file an affidavit with the probate court for them to remain there against their will. So,
Hey, Kristyn,
yeah.
we've got a question in the chat from Dan Hughes from MedStar. I'm going to paraphrase for him. It seems like we run into a lot. My entire career, we've run into with the police saying, well, you can go to the hospital or you can go to jail. Quite frankly, we know that's illegal and everything. What are your thoughts on that? I mean, we do it, and it's usually done for the benefit of the patient, to be quite honest with you. But, what are your thoughts on that? Because that's a real gray area for a lot of us.
Well, I mean, I feel like the only time, I guess like the only time you should be taking somebody to the hospital would be if they have like an actual medical or psychiatric emergency. And the only time you should be taking somebody to the jail should be if they've like committed a crime. So that's kind of like, I feel like people they almost use the pink slip in like a punitive way, where it's more so should be like a medical treatment, if that makes sense. So I don't know if I answered that, but I can definitely agree that I've seen a lot of issues with how the pink slip is used. So like, yeah, you need to go be admitted psychiatrically versus go to jail, but like under what? I guess like you would have to have a charge, right? Would be my thought process. I don't know.
Well, how it usually goes is whatever the situation is, and then you're standing at the back of the ambulance and the guy says, I'm not going to the hospital. And the cop says, well, if you don't go to the hospital, I'm going to take you to jail. And I mean, now it happens in other situations too, but I'm just talking in the psychiatric patient. I mean, maybe someone they might be having somewhat of a crisis, but they don't deserve to have their freedoms taken away. I'm not sure how to word it.
Yeah, and it is like that again, like it is that like that fine line, and that's why I always try to remind about like that getting them to the hospital is for the assessment piece too. So maybe not some like so not so much like pushing like okay, we're going there, you're going there and you're going to be admitted for the week. It's like, let's get you there to get you assessed. So I feel like to say like you either go to the hospital or you go to jail, I just feel like that's just being like,
It's almost two totally different.
yeah, it's like
one's criminal, one's
not even like
medical.
related. So I feel like that's just like a really crappy like person to say to do that. But I get that happens. Because yeah, like how are you gonna like if somebody is if you have the ability to like pink slip somebody, then that's what you should be doing. It shouldn't be going towards like a criminal. I think people are either very pink slip happy or they're so nervous about it because they're so afraid of like I'm taking away somebody's rights. Are they going to sue me? But again, like remembering like from like, and I understand, I think you said that somebody from law enforcement potentially going to speak, or I don't know, but
so.
it's more so to get them to that place to where they could be appropriately assessed too. And I think sometimes when you look at it that way and you talk about it that way, it makes it different. It's like the police officer isn't saying, I think you need to be hospitalized psychiatrically, because they haven't done a full psychiatric assessment. They're just saying you need to go to the hospital to be assessed by somebody because you're not safe right now. And we need to make sure you get there safely, if that makes sense.
Kristyn,
I
I
may
just got a
add-
text from one of my law enforcement buddies, and I posed that question to him, and he did say that cop is just being lazy. So you are correct in saying that if there is a medical need, they should 100% be filling out that pink slip and justifying why. And I think we know that, but I can also see how the EMS person is put in a predicament, because it's happened to me with a police agency, and they always try to push their force and say, look, go with the ambulance and kind of get out of my hair, or I'm going to take you to jail based on something. So again, I think it goes back to the individual officer, the training of that department, and utilize the pink slip to what it is, and enforce the law for what it is. Well, and I've even tried to get the law officer or the law enforcement to fill out a pink slip for some psych, and they're like, nope, too much paperwork. And then it goes on to say, well, if I fill out this pink slip, then the city of or the township of whatever is on the hook, and that's false too, because that's what mental health boards are for, and that's what levies are for. So I just want to clarify that the police officer that I did speak to, very, very informative. He's actually like a lieutenant in the police force, and he said that officer is being lazy, and just ask for that pink slip if you're afraid that patient is going to get abandoned or leave or threaten you in any way. And then if not, then ask law enforcement to, I see no medical need. You never want to get confrontational, but what is the medical need? And, try to pull that law enforcement officer to the side and just say, look, I can't take him. What's the reason for taking him? Would you rather fill out a pink slip so we can have it official? Because we both know that patient can ask us to stop the ambulance on the side of the freeway.
Exactly. Yeah.
Just get out, or they can just walk out of the ER. And again, most of these law enforcement agencies that are in hospitals are not really chasing after these people anymore. They're just protecting the hospital. So that's the correct way, according to the law enforcement expert that I reached out to. But you were right on topic there.
And even like and that was one of the things, like when I worked in the primary care setting, like some of the primary care physicians would be like, I know this patient needs to go, should I pink slip them? And that would always be my response to them was, do you feel comfortable if on the way to the ER, they decide they don't want to go anymore and they go home? And if the answer is no, then I'm usually like, okay, well then you probably need to consider that. So yeah, it could be very gray, but again, like if you can validate that you made this decision in the best interest of your patient and you were concerned that they were a threat to themselves or somebody else, like that's going to be upheld much more than if you were just like, well, I didn't really think they were serious about it, and then they ended up doing something. So good resource. I know not everybody's from Mahoning County, but this is actually probate court Judge Rusu. He did a really good video on pink slips and just like what they are, how they work, the very basic information of it. So if anybody ever would like to listen to it, it's a quick little video I think is very helpful on explaining that. So I know I touched on this a little bit, and again, not so much what you guys necessarily need to, but just to kind of be aware of some of the things that work on the background for trying to prevent or, you know, be on top of suicide. Is lethal means counseling is a huge thing right now. We focus a lot on this in primary care and other settings. It's basically how can we, you know, like with anything else, we do preventative health care. We try to do preventative health care, exercise, do this, do that. So with suicide, that's kind of like where lethal means counseling comes in. So we want to identify like what the risk factors are, what methods are available before this patient even has the ability or even has like the thought or, you know, that drive to attempt to harm themselves in some way. So this is what a lot of times on the background we're working with patients on. So like that's where gun safes come in, medication, really getting family involved. So, you know, like if somebody you're like you determine this patient isn't actually, you know, an active risk, they're not actively suicidal or something like that, but, you know, there's clearly some mental health issues going on and they're agreeable to, you know, have the families there, like how can we get them involved so that we can make sure that this person's safe? You know, if this happens again, this is what you need to do, who you need to call, things like that. So this is just an example of like what we would give people for like walk-in behavioral health services locally. So we have a few different places where people can literally walk in for services. And then the crisis numbers that we give to people, like the suicide prevention helpline, things like that. And then this is just some basic like information, I guess, when we talk about like prevention. So they have found through research that we are no more accurate than chance at predicting suicide in the next 6 months. So it's actually kind of disheartening. A lot of the research that they've done have found that it is very difficult to, oh, Jesus. Okay. It is very difficult to really identify, you know, risk factors and things like a lot of the things that we always thought like, oh, like, okay, these are all the things that, you know, maybe make somebody high risk. They ended up finding that a lot of that wasn't actually true. So a lot of it was like causation versus correlation. There was a little focus on like protective factor. There's often a long time between like the research studies that they did. So what they're doing now is focusing on like these different risk algorithms. So this may be something that you guys will see in the near future. It's kind of like more of like a new hip, I guess, psychiatry thing. The mobile assessment for the prediction of suicide, where they're actually like looking at people's tone of voice, music choice, language use, photos, sleeping patterns as a way to determine like who's at risk for suicide based versus like what we had been studying for a million years. And we're finding like we're having a hard time really, you know, doing what we should be doing with this information. So this kind of goes in with what we talked about before with the part of the pink slip that isn't necessarily somebody who's actively suicidal or homicidal, but we're looking at activities of daily living. So when was the last time you slept? How's your appetite and eating been? Have you been taking care of yourself? And then some other questions you can ask. Are you active with a counselor or a psychiatrist? Have you been hospitalized psychiatrically? Do you take any psychiatric medications or have you taken any in the past? So again, it's not just, well, they're not suicidal, so they're fine. You know, there's a lot of those other psychiatric presentations that could be concerning and that could, you know, somebody not sleeping for a week and having active psychosis of hearing voices telling them that, you know, what they're like super paranoid or whatever, like that's still somebody's still very high risk and probably still needs to be at least assessed to make sure that they're safe. So just briefly, some techniques when it comes to dealing with psychiatric patients. don't make quick movements, respond honestly, but don't foster unrealistic expectations. So this is, again, where we come back to the whole, like, you either go to jail or you're gonna, like, you don't want to, like, threaten, challenge, belittle, or argue. Always tell the truth. So, like, yeah, like, some of the things that you share with me are very concerning. I think that, we need to look at transporting you to the emergency department so that we can ensure that you are assessed appropriately and we can make sure that you're safe versus, being manipulative or secretive about it in some way. Obviously, with psychosis, you don't want to play along with it, but you also don't want to deny it necessarily. Be prepared to spend time on scene. Obviously, you're never going to leave the patient alone. Don't force decision making. These are going to be, again, longer term calls. And I think that that's sometimes why people, are like, oh, the psych calls are like the difficult ones. And they are, because they're not cut and dry. A trauma that you come up on, you know what to do. Like, this is what we're doing. These could be so difficult. So you really got to use those assessment skills. Always ensure pre-planned exit or escape route. Encourage adaptive coping. So that's where we talk about, if somebody is having a panic attack, like, all right, breathe with me. Like, take a deep breath. 4 seconds in, hold it, 4 seconds out. Like, those little things could be super, super helpful in that moment. Every person has limitations. Each person has a right to their feelings. Everyone handles crises differently. So just because it's something that maybe you think isn't a big deal, somebody else may really experience as a crisis. Emotional disturbance is normal, no matter how small the injury or the disaster. And remembering we all have a different window of tolerance. And for some people, it could be just as real as physical. And this goes for you guys too, like in EMS, that's not what this is about today as far as the presentation, but, a lot of this, you guys are experiencing a lot of trauma and things like that as well. So, making sure you're aware of those things and then coming to terms with your own feelings and leaving them behind. So regardless of how you feel about, the patient that you're pretty sure in your head is not actually at risk, but is reporting that they're actively suicidal, or the person who's shooting up heroin that you respond to a million times, like in your role, like, it's not, to be, you got to kind of put that aside. Like, I'm here to do a job. I got to make good clinical decisions and what's best for the patient. So the last thing that I'm going to go over real quick, and then if you guys have questions, because we have like 5 minutes after that, is I thought that this was really interesting. So there's a psychologist that I follow, and she, for like a research study or something, had somebody in the field of emergency medicine ask her to get people to tell her during a psychiatric crisis or emergency, what were some things that EMS said to me to make you feel better, or that helped you through that crisis at that time. So I kind of wrote down some of them because I felt like that would be, these are like, I guess, from the mouths of patients who have been in that situation. So one thing that someone said is taking me seriously and explaining to me what was going on with my body and that I was not in danger. So I'm assuming that's probably like what I talked about with like the panic attack. Like, okay, like, this is what's happening during a panic attack. Like, it's super scary, being very validating. Or somebody said that they said, I'll stay by your side until this is over. Let's go through it together. Again, like that, somebody who's in that very hyper, like, anxious state. I thought that was super nice to say that. And then even just like people they said, like, paramedics who will say, like, we've all been there before. So maybe not so much like self-disclosure, like, oh yeah, I'm on the same meds as you or anything like that, but more so like, we've all been here. Like, you're gonna be okay. You're going through. So just being able to really be human and empathize and realize that these people, nobody wants to be where they are when they're in this having the worst day of their lives. So how can you add a little piece of humanity to make it so that they it's better than it was before. So that's all I have. So I can get questions, and then that's my email address if anybody has any or wants any more information or has
And I'll
questions.
send these to Larry to
Okay.
post too.
Okay.
Danny Hughes followed up with a question and says, do we have to transport or not listen to the police or tell them no if the patient's A&O times 4? And I just want to hit on this, that if a patient is alert-oriented to person, place, time, events, that they're able to refuse any treatment at whatever time. It is up to that police officer then to invoke that emergency hospitalization form and write it down. And if you're kind of in that, what do I do? Do I take that patient and take them, or do I tell the cop no? Take the law enforcement officer, talk to them in private and be like, look, he or she's refusing, and they have a right to do that. But obviously, if the patient's pink slips, they go to the hospital. If the patient's not pink slipped, they don't go to the hospital. They don't have to go. EMS can't take them. It's just a fact. They can't take the patient if they're not pink slipped or pose a medical problem.
So now, like Larry, in that situation,
Has his hand up. What's your question, Nick?
Oh, Kristyn was talking. Kristyn was following up.
oh no, I was just gonna say in that situation, then like I'm assuming like they document all of that too, right? Like it's very well documented, like this was what was reported, and then this was what happened with the police, so that like ultimately, like if the police is the one that's making the decision to not pink slip them, that's not on EMS, correct?
Well, that wouldn't be, but I do know that there are some people or agencies out there that will say, you know what, EMS isn't needed, so they'll clear the call without charting anything. There might be a time where you would get a refusal and say, hey, sign here. Let's just say that you don't need us. You're not going voluntarily. That you can refuse, and that would be the opportunity to go ahead and document your interactions with the police, or write an incident report up and submit it to the to your employer. But sometimes a lot of EMS are just saying, you know what, not needed. Let me get back in service and not worry about the chart. But it's definitely, we do definitely need to have some police officer / EMS interaction topics on here. And I'm working to try to get some police officers to speak on that, for things just like this. But yeah, it's all up to the police. And I can tell you firsthand that when I went on that patient, that psych patient, that they used the go to the hospital, go to jail. And I spoke to the officer and he said, well, he can't stay here. I'm like, well, respect, that's not my problem. I don't know what to tell you, but I can't take him. And I've had people who went, quote unquote, voluntarily and took them around the block. They said, pull over. Okay, out you go. So, and on the middle of 680 Youngstown, pull over and off you go. Is that a threat? Is that a danger to them? Sure. But they have the right to refuse anything at any time. And as long as they're not pink slips, they can get out of the back of that ambulance. And it's happened before. So, that's kind of where we're in a gray area a lot of times.
Yeah.
Hey, Matt, Kristyn, this is Nick. 2 questions for you.
Okay, now Nick, ask your question.
Okay, can you hear me?
Mm-hmm.
Okay, perfect. First off, things that I've encountered from PD when they're handing us a pink slip, what all needs filled out on there? I assume everything, but is there something that they can leave blank or anything like that?
So they're supposed to be filling out like the patient, like I think it's like the name, the date, the time, the facility that they're going to. I mean, really, like you guys should know that when the transfer is occurring, and then they should always be checking the box that says specifically like what the reason is, those 4 boxes. So it's like suicide, homicide, and then it's like not taking care of myself, or person just needs transported. They have to hit that box, and then they have to do the narrative, and then they have to sign it. And then the other stuff that's on there would be like a secondary signature. That's why when we say like if somebody's transported, like, so for instance, when I worked in Mount Carmel, we didn't have a psych hospital at the emergency department that I worked at. So if EMS would bring somebody in on a pink slip, our doctors would have to redo another pink slip, because technically that pink slip is titled to come to Mount Carmel East. But if they're getting admitted for psych, they're not going to stay there because we don't have a psych. So though that like piece is important, obviously, like, so that again reiterates, like, it's getting them to that place that's identified on there, and then their signature and then their reason for it should all be filled out.
Okay, well, that actually pretty much answers my second question, because I've encountered from the health officials or health officers more than PD, but the PD that I've encountered, I'm assuming got trained by those health people. They would not fill out the sending location because they would say that the ER can't redo this pink slip. And so we're not going to put in that they're going to ABC ER because the ER is going to send them to North Coast or something like that. And then we would get into the argument with them that, no, we need to have that sending location, otherwise it's not valid. And it would be a back and forth. But if you're saying that the ER is allowed to redo it, then.
That has always been my experience with even, I mean, when we would send them from primary care, I would put on there St. Elizabeth's Hospital, Youngstown. You should be putting like where you're sending them to. That has always been the way that we've always done it. And again, like from the emergency department. So unless that's like something that's changed, might want to get more clarification.
I've only encountered it in Stark County. So I've worked in several counties. I've only encountered that problem in Stark County. And that's same with those PD down there, because I'm assuming they're being trained by the same health officials. But yeah, they would refuse to put whatever ER because they would say that they can't. And so then it would put us in a pickle of, well, the mile down the road when the guy wants out of the back of the ambulance, you're telling me it's legal, and I've been trained that it's not legal. So, but good to know.
There's another question in the chat that says, does alert and oriented times 4 equal competence? And I'm gonna take that as no. Competence can be made by a judge, but what we're assessing with alert and orient status is capacity to make a decision. And so capacity would be done by a clinician or somebody to make that determination, and competence is done by a judge at a legal hearing.
Yeah.
Matter of fact, Larry, they did change that, and you probably read that in emergency medicine, because in emergency medicine they changed that where they no longer call patients competent, because exactly what you said, that can only be determined by a judge in the court of law. And you're right.
I see your question there. Are pink slips good across state borders? In my experience, I'm not the expert, but in my experience, the answer is no, because when I worked in Brookfield and we'd get people pink slipped, it would be to Trumbull. It would not be to Sharon Regional. And we were told it was for that reason, but that, again, that's not a legal opinion or anything. That's just anecdotal evidence from myself.
Right, because even some states don't even have pink slips. Like Pennsylvania, it's like a whole different, like every state is different. So yeah. But I mean, even like, I guess like with the following up on like the competency and the capacity, it's the same thing with like, I get people asking with like power of attorney, and like they think like, well, I'm going to be able to make all these medical decisions for this person. But that's exactly right, in that until you've had a judge determine that this person does not have the ability to make their own decisions, then, you know, they're still able to make those decisions, whether they're good decisions or not.
That's actually a very good point. You should never write, EMS should never, ever write anywhere on any document that the patient was competent. And again, as Larry pointed out, it's the capacity to make a rational decision is what it is. Because again, competency is a legal term. And that's why emergency medicine has moved away from it. So never, ever write on your run report, or, you know, when you're documenting your patient care, or, you know, never put the patient was competent, because you can't do it. And if you end up going to court, they will tear you apart because it's a legal decision.
Steve Mock, do you have another question? Your hand up.
Can you hear me?
Yep.
Okay. To follow up on that, the whole reason I asked that is, if the patient is alert and oriented, and they don't want to go, and police doesn't want to push the issue, but we do have the feeling that, like, say, they are going to make a bad decision. But like say, talking again about, the police wanting to, being lazy and not wanting to fill that paperwork out. What do we do then when they're not willing to fill out a form and we feel the patient does need to go, even though they're alert and oriented?
Well, that I think, Steve, what you're going to find is that the emergency department is going to hate you for it. But as you're saying, if the patient is alert and oriented ×4, and you're saying to yourself, okay, this patient's able to make a rational decision right now, then you cannot force them to go. And Larry said it, or Matt said it too. If they tell you to pull over on the side of 680 and they want to get out of the ambulance, you try to talk them out of it. But if they demand it, you let them out. So in that situation where you're saying to yourself, I really think this patient might hurt themselves and the police won't pink slip them, the ER doc's going to hate you for it, but I would say get on the phone, call the emergency department, ask to talk to the doctor, and then have them make that decision. I don't know, Matt, you might want to chime in there from Trumbull's perspective, but at least, you and the doctor may say, well, there's nothing I can do about it. And then at that point, you document, and you leave the patient. And hopefully there's a family member or somebody there who could be there with the person. But that's a tough situation because, if you take this patient against their will, you're going to be charged with assault, with battery, with kidnapping, and everything else. But then again, if you leave them, it could be the patient commits suicide as soon as you, pull away from the house. So, it's a real tough situation. But I don't know, Matt, from the emergency department perspective, and again, the emergency doctors hate it. They hate it because you're putting them in a position for them then to say, well, all right, bring them in against their will. And then at that point, then, you're okay because it's a higher medical authority making that decision. But they hate it because they don't want to be put in that position either. I don't know, Matt, if you have a different perspective on it.
I actually have had experience with that. It's been several years ago. The police were not available. The woman was actually in a doghouse barking at me with a paramedic textbook. That's no lie. That's a real story. And when I called the doctor, and I'm like, she won't go. She won't. He told me, he said, no, you get her and you bring her in. I trust your judgment. And I think that's going to be the key when you call in, just with anything else. Know what you're talking about. And I can't account for any doctor's personality or anything like that on the phone, but I'm pretty confident that most of them will talk to you. And hopefully, trust your judgment. That's what they're supposed to do. You're supposed to be their eyes in the field and you're calling them for help and for backup. So I would hope that if you thought enough to call and say, man, doc, I'm really in a bad spot and this is what we have going on. Geez, I would hope they'd help you out.
I had a call one time. It's interesting. Actually, this was in Poland where there was a young kid. He was a young kid. He was probably in his early 20s. And he lived with his mother, and he was down his basement. And he had 2 Dobermans, and these dogs are mean as hell. And his mother called us, and she called the police at the same time. I think it was Poland City, if I'm not mistaken. This kid actually took a long, I don't know if it was an extension cord or lamp cord or something. He took the cord, he bared the wires, and he wrapped them around his torso. And he stood there with the end of the cord next to a plug saying that he was going to plug it in and kill himself. And nobody could get to him because the dogs were vicious and wouldn't let anybody go down the steps. And the Poland police officer said, nothing I could do about it. And he got in his car and he left. And, unfortunately, we called the emergency department. They're like, well, there's nothing we could do about him. If he plugged himself in, then I guess bring him to us. And we ended up leaving. And I don't know what the disposition of that. I don't know. But, it's a sad case because, Steve's saying, we felt like if we leave, this kid's probably going to harm himself. We don't want him to harm the mother, too. But we can't get to him. We can't do anything. But again, he was alert. He was oriented. He told us everything we wanted to know. He was able to make, there again, you say, was he able to make a rational decision? Probably not. But at the same time, he was alert and oriented, answered everything. And there was no way we could get to him. So once the police pulled the plug, we pretty much had no choice but to leave too. So sad situation. And these are tough. tough situations. And, and one of the dangers, you have to realize too, psychiatric, the three top situations where EMS is injured and killed, the three top ones: domestic violence, drug and alcohol, and psychiatric patients. Everybody thinks like, EMS, they're getting killed on, homicide scenes and shooting scenes and stabbing scenes and so forth. They're not. And the reason why domestic, alcohol, and drug and psychiatric is because of sudden behavior change. And that's what you have to be very careful. So you have to protect yourself too. So I don't know. These are tough situations.
Will Ferrando, your hands up. Will, do you have a question? No. Okay.
You guys
there
able
are
to hear me now?
Yeah, there you go.
Oh, okay. Just kind of, I don't know if this is something for Matt or Joe, if you have any idea on this. Just recently, we had a older gentleman, kind of going through some stuff. We were working with him because he made some comments that he was, willing to end his life, but didn't have the means to, was too weak to do it, that kind of thing. Luckily, in this situation, he was on the phone with a caseworker on a recorded line. So we kind of were covered from every aspect.
Yeah.
But we finally convinced him to go to the hospital due to his condition. He had some other stuff going on medically, but we were able to convince him to go. And then once we got to the hospital, he kind of flipped the switch. And I think they were idle threats, but he was kind of making it sound like, you guys kidnapped me and brought me here and kind of talked me into this. So obviously with us being on a recorded line, we were covered at that point, but
right
outside of that situation, if that would happen, like, and you weren't on a recorded line like that, do you have any input or, what we would do in that situation?
Right? Like you just document the truth.
Well, you document. I was talking to Larry and Matt, and I said, I've collected over the years. I've done, quite a few expert witness cases over the years, and both plaintiff and defense cases. They're tort cases, but I can tell you this: that the best defense you have is you document, and it's not enough just to document in the PCR. What you need to do is in situations like that where you feel like this is an unusual case, again, you pull out a legal pad or you do an incident report and you document, shortly after the call, and you just document because you have the freedom to write what you want on your legal pad, and then you date it and you sign it and you tuck it away. Because if not, you might find 7 years down the road, 9 years down the road, you now are going to do a deposition and you're like, well, that was, 6,000 calls ago. I don't remember it, and so then the key when, these attorneys are slick because one of the things they want to do to discredit you is they want to trip you up. And if you have nothing to rely on, you're trying to rely on your memory 6,000 calls later, and something that happened 7 years ago, it's so easy to trip you up. And once they trip you up, they discredit you immediately. And that usually is the case. So don't, again, document. And again, feel free to write your own notes, sign it, date it, tuck it away. Because, that's probably what will save you. In a case like that, you document everything, what the guy said to you, because that's stuff you're not going to put in the PCR. What he said to you, his agreement to go. Yeah. Well, you could put like the patient agreed to go, but you're not going to expound on it. Like, his demeanor and things like that, and especially today, the PCRs are pretty, they're more check box, click box and so forth. And it's taken out a lot of the narrative. So document. In all these cases, the best thing to do is document. And again, if you leave the scene, again, document. Just don't have them sign off on a refusal. Man, document, because again, it could be you they're coming after.
Got it.
Joe, two things. One, with respect to your legal pad, there's been some people asking me. With that though, if you get subpoenaed to court, you would have to present that as evidence, right, for other people to kind of like have. Yeah. Yes. So evidence, finding evidence or whatever. So there's been some people having confusion about, oh, I can just keep a legal pad and never present it until I get on the stand, which is not correct. So I just wanted to make sure that people understand that is evidence and has to be handed over to both sides, and how that would present a challenge when you do go to court if you did not present that ahead of time.
And Larry, that's a great point, because again, it's discovery and everything is discoverable. So if you're using those notes to rely on to refresh your memory, it's discoverable, meaning that you have to present that, just like you're saying, to both sides. So if you write some stupid notes on the side, like this patient was an asshole or da-da-da or whatever, that's going to court, and they're going to blow that up on a big screen and show it up there. And here's another thing too, believe it or not, though I was doing one case where they actually took the written PCRs before the computerized PCRs, and they took this person's PCR and they blew it up, put it on this 8x10-foot screen, and there were so many misspellings and grammatical errors that they basically discredited the EMS crew. They made them look like they were stupid. And it really had nothing to do with the case. But again, so if you are documenting and you are writing your own personal notes in the legal pad, again, use all the legal, the right legal practices, like don't scratch something out, put a line through it, initial it, and things like that. Because if you start scratching things out, they're going to say, what did you do? What did you redact? When did you do this? And so forth. So, but absolutely, Larry, if you're going to use it and you're going to refer to it, like if you said, well, I referred back to my orders, those orders are going to be part of the record. Everything becomes discoverable at that point to both sides.
Yeah, and then the other thing I think to coincide with is that everybody's talking about documentation and what if it's not on the recorded line. But just I think Ohio has immunity for EMS and police officers and whatnot, but immunity for literally all conduct except for that rising of willful or wanton negligence or misconduct. So if you're acting in the patient's best interest, you're doing things that you think are appropriate, except for taking them against their will, again, they have the capacity to refuse, then you should be covered. And that's something that, some people are questioning as well.
Right.
So,
right.
Thank
Always
Danny,
error to benefit the patient. Always error to benefit the patient.
Danny Hughes had his hand up and down, and then after Danny, Marsha. Danny, do you have any questions? Going once, going twice. Marsha.
I just had a quick question in regards to documentation. The whole conversation tonight has been in regards to true.
She took her hand down. Dan, now your hand's back up. Do you have a question? Oh.
Sorry, Matt.
My bad. I'm
everybody
having a
muted.
malfunction.
So we'll go with Marsha and then we'll go with Danny. Marsha first.
Go ahead, Marsha.
Okay, can you guys hear me? Yep. Okay, I just was going to ask about the documentation, and it seems like the material tonight was based on true psychs. I know that was probably a no to say that, but you'll understand why I say that in about a second. Within the past month, I've had patients that say, well, this will look good for my SSI. It's a 19-year-old patient deliberately acting out with the future goal. Also, my girlfriend is in whatever psych they want to go stay with their girlfriend. So with those statements said to us, are we to document those or not? And when we repeat those to staff, obviously, then it seems like we're just believing the things they're saying. So is that wrong? Because if somebody's saying that to me, I'm not believing them so much.
So, I mean, I guess it's not like, so you can only go off of what they tell you. So if they're telling you like, this is what it is, then I would think that that would be what you would document. And then it's not necessarily though your decision of whether or not they're going to be admitted then. So like you're just telling the truth at that point. And like, this is what they're reporting to me. I'm assuming if they want to go there, they're going there voluntarily. So you would tell so yeah, would it maybe hurt if their goal is to get to the psych hospital if you say like, well, this patient told me they want to go here because their girlfriend is there. I mean, it maybe will hurt their goal, but that's what the patient reported. And I mean, obviously I come from when we talk about like documentation and legal stuff, I come from like the therapy side of things. And we do the same thing where we have like our legal therapy notes, and then we have like notes that we could keep on the side. But it's the same thing. And it's always like, document exactly what is being reported. And if you're doing that, then like, even if the patient says like, well, that's not what happened. Well, that's what was documented in my legal document. So then at that point, it becomes like their word against your legal document, if that makes sense.
It's
So
like an objective chief
Mhm.
complaint.
So I don't know if that answered it.
Yeah, thank you.
Yeah.
Yeah, it's like an objective chief complaint. It's objective.
Right.
It's not subjective. It's objective because you're documenting exactly what they
they're
said
saying.
in quotes.
Yes.
All right, Danny Hughes has the last question, then we're going to switch topics here.
Yep. Okay, I'm sorry. All I was wondering is, okay, because when we deal with PD anyway, they're like, you go to the hospital or you don't. And yes, you guys answer that question. But my feeling is if there ain't no times for, they can tell you, well, I want out, everything like that. We're not legally responsibility. Is that correct?
As long as they can they could say that the patient is able to make a rational decision.
I don't know. Did you hear that?
No, go ahead.
Okay. You want me to say it for
Yeah.
you? Okay. As long as you could say that the patient is able to make a rational, yeah. So again, like if the police is not willing to pink slip them, then yeah, and the person's alert and oriented.
And they're not. I mean, half the time we show up, they're saying that choice, and then they're saying, well, you got to go with them or you're going to jail. There ain't no times for. What are you going to do? That is my question.
You can't, if they're refusing.
Yeah,
you
I
can't
mean, but
take
if
them.
they're if they're
You can fill out the pink slip. What are you going to do?
wait, if they're not willing to fill out the pink slip, you're saying?
Correct. We run into this all the time.
And that kind of goes back to, again, like you can't take them, but then that's where, you're in that weird spot where like they talked about, could you call then the ER if you have genuine concerns? Or one of my questions, and I don't know if somebody in law enforcement would help with this, like if you're just dealing with a cop who's just like, and you're like really concerned, I mean, isn't there an option to like, is there a sergeant like that you could speak to or something along those lines? I don't know how that would work in the EMS police world, but like, I would think like if it's something like, but you can't take them unless they're pink slipped.
Okay, because a lot of times they'll say, well, they're going to go voluntarily and the cop's not going to show up at the ER and fill out the pink slip.
I would say it sounds like you have a lazy police department, and please, I have all the love for the police department. But here's what I would say. I would say we've already determined that the patient has capacity. Therefore, the patient has capacity. If you can pull a police officer off to the side and say, we have no basis to transport him, he's refusing, and have him sign a refusal, and he's already signed off. If that upsets the police officer, go to your immediate supervisor, have your fire department, your captain, or your supervisor of the ambulance company, reach out to that police department, try to figure out a solution. But you're going to be caught in the crosshairs. Or if that police department decides to take off, I mean, you could play dirty and be like, okay, now if you don't want to go, sign here. But we don't want to do that. We never want to do that because it's either the patient needs to go and they need to go for the right reason, or the patient committed a crime and they need to go to jail. So I think there's some mending between the ambulance company and the police department. But again, capacity, they have the capacity. They don't have to go. You have no reason to take them. That puts you at jeopardy. And do you think that that officer who said, "Oh, I told him to go to the hospital, go to jail," or do you think he's going to say that, or do you think they're going to say, "Well, I left them in the hands of EMS, and they made the decision. I did not fill out a pink slip." The fact is, they did not fill out a pink slip. The fact is, you took them. The fact is, they didn't want to go. It's going to come back to you. So take what you learned today with what we said. Again, I had law enforcement on the phone with me when I was telling you these facts. They're also on the phone with me now. It just sounds like a gray area that you're in, and I'm sorry about that. And I think that your company needs to reach out to the police department.
All right, thank you.
Yeah, sorry we can't give you definite answers, but the law is the law, and that it's going to go for everybody, whether it's a pink slip, whether it's you, and whether it's the police officer trying to get that patient to go. So,
Right.
But
thank you very much.
You're welcome. I do want to thank Kristyn Woodward, Joe Misovich's daughter. She did a great job tonight, and she provided us with a lot of insight on mental health and her experience, and how it relates to EMS. And I think she did an excellent job. And Matt Gordon's going to go ahead and reel up his presentation here. But there's her contact information. She's going to send me the slides. We'll put them up on the Google Classroom. And if you have any questions, email us and we'll email her. Or you can just do it right there. But I'm going to let you take a break on your own, but we're going to just roll right into this. Matt's going to take over here. If you need to leave, go take a break and come back. And we're going to try to wrap up on time so that you guys can get out of here. So as soon as Matt's ready, we'll be rolling.
Okay, everybody. It's Matt. You all know me. I don't need to introduce myself anymore, I don't think. I think we've all met. My talk today is on medication administration. We're going to be pressed for time, so we're going to gallop right through it. If you need to stop me on anything, please feel free to stop me on it. But we're going to proceed right through. Just like everything else, pharmacology changes constantly, and we have to change with it. EMS providers often have to make medication decisions quickly and with limited information, and we use very dangerous drugs. We're responsible for administering the appropriate medications at the appropriate time in the appropriate dosage, and we can take steps to reduce the opportunity for errors that we make. The Controlled Substances Act of 1970 classified certain medicines as medications as controlled. You can see the schedule off to the side there. Of course, one that's a hot topic these days is marijuana, that is still a Schedule I drug federally, and that's changing. That's no news. That's everything, and that's all in the news. That battle's been going on for a while. EMS providers are likely to carry and administer Schedules 2, 3, and 4 meds. And these medications require locked storage, significant record keeping, and a very controlled wasting program. Medications come from a variety of sources. Plant-based, minerals, all these different things. In addition to these, there's synthetic, genetic, and semi-synthetic medications, with a lot of research going into the genetic side of medications these days. But still to this day, there's different molds, fungi, and other things used in the manufacture of a lot of the medications we still use. Some of the things derived from plants are atropine, aspirin, and dig, morphine. Animals, we get heparin, antivenom, thyroid preps, insulin. Microorganisms, we get streptokinase and all of our most of our antibiotics. In the minerals, you know, mag sulfate, phosphorus, calcium, iron, things we use every day. I'm not going to sit here and go through every single form of medication that we have. Capsules, tablets, powders, droplets, parenteral solutions, skin prep, suppositories, inhalers and sprays. Sorry about going so fast. Medical asepsis is the practice of preventing contamination of the patient by using aseptic technique. Antiseptics destroy all living organisms and is achieved by using heat and gas or chemicals. It's not feasible to maintain a sterile field in an ambulance or in the outside environment, so we practice clean technique to reduce our risks. Can't stress hand washing, gloves and proper glove changing, and PPE and proper PPE donning and doffing, and cleaning our ambulances and our hospitals. You know, we have to really get down in there, get nooks and crannies, and get these ambulances clean. Antiseptics are used to clean an area before an invasive procedure, and they're not toxic to living tissue. Some of the more common ones are chlorhexidine, isopropyl alcohol, and iodine. Disinfectants are in fact toxic to living tissues and should never be used on a patient. Only used for non-living objects such as inside the ambulance and your non-disposable equipment. This goes for all the different wipes you see in the hospital that we have. I can't even name them all. The wipes, the sprays, all those things. Not for use on a patient. Standard precautions, we need to protect ourselves. Minimum are gloves and eyewear. All body fluids are considered infectious. What's the saying? If it's wet and sticky and it's not yours, leave it alone. Disposal of contaminated equipment. Used needles must be disposed of immediately, carefully, and properly. Can't emphasize this enough. As soon as you're done with the sharp, it goes in the sharps container. It doesn't get stuck in the bench seat. You don't throw it on the ground and stand on it. You know, all these different things that we do, we have to, you got to put the sharps away because inevitably somebody's going to sit on it or run their hand across it or something. Things you should be familiar with the medications that we give is the name, the trade and the generic name, because what makes something more confusing in EMS if we don't give it 2 or 3 different names. The class, the category of med, and meds with similar characteristics. The mechanism, how does it work? We shouldn't be giving any medicines that we don't know how they work. Indications, what does it work on? Contraindications, adverse reactions and unintended consequences. Interactions, effects when mixed with other meds. This is where history has a big play. And one of the things that Kristyn talked about was, you know, multiple doctors prescribing and everything. We need to be aware of these things. And don't be afraid to ask about herbal medications and things like that too, to find out, you know, if there are interactions. Its form, how is it packaged? Is it a liquid? Is it a pill? How do you give it? Its administration. And we need to know the 3 values of duration: the onset, the peak effect, and the duration. The onset is how quickly the medication takes effect. The peak effect is how quickly it gets to its maximum effect. And the duration is, of course, how long it's going to last. And we should also always be concerned with any special considerations, you know, certain medical conditions or anything that might be influencing the medications. In the interest of time, I'm not going to go through the metric system. I will say this, I'm pretty sure everybody has this down pat by now. Weight, convert by multiplying or dividing by 1,000 to get to the next unit of measure, or just move the decimal point in the metric system. Converting pounds to kilograms is the patient's weight divided by 2.2, or divide the patient's weight by 2 and then subtract 10%. Do the weights, ask people their weights and things. We're not as good at guessing weights as we think we are. You should be familiar with the following terms to calculate dosages: the desired dose, which is the quantity of medication to be administered to the patient; the concentration, the amount of medication in a given volume; volume is the amount of liquid in which a medication is dissolved; and yield is the amount of medication in 1 milliliter. So by using this formula, you can easily calculate the concentration of medication in 1 milliliter. The total weight of the med divided by the total volume in milliliters equals the weight per milliliter. So we'll do an easy one. Diphenhydramine 50 milligrams in 2 milliliters. 50 divided by 2 is 25 milligrams per milliliter. If the concentration is listed as a percentage, convert the percentage to a fraction, convert grams to milligrams, and divide the numerator by 100, divide the denominator by 100. So let's take 1% lidocaine. 1% indicates that there's 1 gram per 100 milliliters. So 1 gram divided by 100 milliliters equals 1,000 milligrams divided by 100 milliliters equals 10 milligrams per milliliter. Pretty easy. So how do we calculate the volume to be administered? We want to take the desired dose in milligrams over the concentration in milligrams per milliliter will equal the volume to be administered. And if your dosage is weight-based, don't forget to convert to kilograms. So here's everybody's favorite things. So this is a pretty typical medication equation. So we're looking for, we have a 60 kilogram patient that needs 10 micrograms per kilogram per minute, and the med is mixed at 200 milligrams in 100 milliliters. The formula is up there at the top. So we have to convert the 200 milligrams to micrograms. You just move the decimal over, right, to 200,000 micrograms in 100 milliliters. Easiest thing to do, cancel out the zeros. The 2 zeros in the 100, take two zeros off the 200,000. We have a 2,000 to 1, or 2,000 micrograms per milliliter. So now we know what we have. So we need 10 micrograms on a 60 kilogram patient. And the other 60 is 60 seconds, 60 minutes, I'm sorry, over 2,000. So that equals 36,000 over 2,000. Easy thing, and cancel the zeros again. 36 to 2 or 18 milliliters per hour. Folks, there's a lot of different ways to calculate drugs, and some are way easier than others. Do whatever you think is, whatever formula works for you and is accurate for you, but use a calculator. A lot of times in our med boxes, we used to keep calculators, but everybody has a phone now. So, and there's great med computer apps out there and everything. Take advantage of them. They're all free. Pediatric drug dosages. We could go over pediatric drug dosages all day because of the weight-based and the complication of them and the high stress and everything else that goes with giving pediatrics drugs. Listen. Get a Broslo tape, get a hand heavy, get whatever pediatric specific field guide that you are comfortable with, and use it. The Broslo seems to still be the standard of the industry, although I see that hand heavy is making a big push. People seem to be pretty happy with it as well. What I'm going to tell you is get it and use it, because in that situation you don't want to be doing math. Excuse me. A parenteral route is administration by anything other than the GI tract, and it's generally quicker and more predictable than giving a medication by mouth. Those routes include intradermal, subcutaneous, intravenous, intramuscular, intraosseous, percutaneous, transdermal, rectal, intranasal. There's a lot of different routes. We've all seen syringes and needles, and we know that the smaller the number, the bigger the gauge, right? Meds do come packaged in a lot of different ways. Ampules, it seems like they're slowly getting away from ampules. They're designed to carry a single dose. You snap the top off, always snap it away from you. I suggest using a piece of gauze to hold the top of the tube as you have the vial or ampule as you snap it off. And always use a filter needle and proper sterile technique. Vials we're very familiar with, glass or plastic bottle with a rubber stopper. contains single or multiple doses. Remember that after the cover is removed, it is no longer sterile, and you need to clean that before you were to draw more medication out of there. And some medications we use need reconstituted, excuse me. Sorry. Probably the one that comes to mind is the one down there in the corner, glucagon, where you push the stopper through, the liquid mixes, make sure you mix it well, make sure there's no precipitate in it before you draw it up. Sorry, I'm falling apart. I thought I was feeling better. Pre-filled syringes. We're very familiar with these because we get to pop the tops off them like Johnny Gage, right? They're packaged in tamper-resistant boxes. We used to take a lot of our medications out of the boxes and arrange them in particular packs and things like that. We really shouldn't be doing that. For one thing, you have more potential to expose the medication to the light, which causes more faster degradation. They're less protected, easier to break, and you lose that tamper evidence. Sub-Q injections, administered with 1 milliliter or less of medication using a 1/2 to 1 inch needle that is 24 to 26 gauge at a 45-degree angle like it shows down in the picture here. And that's what we're aiming for, is the subcutaneous tissue, to get through the epidermis and dermis to the sub-Q tissue. Common sites are the upper arm, the abdomen, and anterior thigh. Step 1, you'll see a lot of these steps are the same for all these meds, okay? Check the medication to make sure it's correct, it's not discolored, it's not expired. Assemble and check your equipment and drop the correct dose. Using aseptic technique, choose and clean your injection area. Pinch the skin surrounding the area, insert the needle at a 45-degree angle. Inject med. Remove the needle, hold pressure over the site for a couple of seconds. Sometimes the injection tends to leak right back out the needle hole, and immediately dispose of your needle and syringe. To disperse the medication, a lot of people recommend rubbing the site in a circular motion, and we should always monitor the patient's condition after we give them a medication. IM injections are administered with up to 5 milliliters of medication. Use a 1 inch to 2 inch needle that's 21 gauge, and IM injections are often used when an IV cannot or just isn't being used. And of course, you see it down here in the corner. The idea is to get that needle into the muscle. Common sites for IM injections are the vastus lateralis, which is the large muscle on the side of your thigh. The rectus femoris, the large muscle on the front of the thigh. That's the one where you often see people giving themselves an EpiPen. The gluteal area or buttocks, and the deltoid. Deltoid seems to be one of the most popular for us in EMS. That's the muscle in the upper arm that covers the prominence of the shoulder. That injection site is 1.5 to 2 inches below the acromion process on the lateral side. Clear as mud? Step 1, we make sure it's correct, it's not discolored, it's not expired. Assemble and check your medication, drop the correct dose, cleanse the area, stretch the skin over the area and insert the needle at 90 degrees. Pull back on the plunger when you're doing an IM injection to aspirate for blood. If you draw up blood, do not inject the med. If there is no blood, inject the med and remove the needle and immediately dispose of it. And then we always monitor the patient's condition in case their lips swell up like that. Another technique that seems to be more widely taught now is called Z-Track. And that's another technique. You prepare the skin, pull the skin and the subcutaneous tissue laterally, and then continue as usual. So when you release the skin, the hole that you put it in is not over where the medication was put into the muscle. And that helps to seal and reduce leakage from the injection. Benefits of IM over sub-Q, we can give larger amounts of medication. Some medications like Epi are absorbed faster and more predictably in the field. The funny thing is that we used to never, ever give FEIM. They thought, oh, you're going to kill the muscle, you're going to kill the muscle, you're going to kill the muscle. And now it's a standard. It's just one of those many things that have changed over the years. More meds are transitioning from sub-Q to IM because of a more predictable and stable outcome. But remember, for any of these methods to be effective, there has to be adequate perfusion to the muscles or to the skin or to the subcutaneous tissue. That's why we don't use IM and sub-Q drugs in a cardiac arrest. Well, one of the many reasons. Intranasal. Intranasal is here to save the world, right? It does have a lot of benefits, though. Intranasal administration benefits rapid absorption and more rapid onset of action than some other methods. A MAD, which is a syringe or a unit dose pump with a spray tip, is used for the administration. Many meds can be given this route safely and effectively, including fentanyl, ketamine, midazolam, haloperidol, naloxone, and glucagon. I have found personally that fentanyl IN works very well. I had a particular patient that there is literally no IV access, and she was in terrible pain, and it really did a great job for her. She said it tasted bad going down her throat, but she was glad to have the relief. All the standard precautions, drop the correct dosage, reconfirm your medication, dispel the air, attach your device to the syringe, explain the procedure to the patient. If you're giving Narcan and you're explaining the procedure to your patient, reassess. Or to a relative if the patient is unresponsive. Stop ventilation of the patient if necessary. Insert the MAD into the larger and less deviated or obstructed nare and quickly spray half of the medication dose into each nostril. Max volume for each nostril is 1 ml. Dispose of the MAD in the syringe appropriately and monitor your patient's condition. I won't get into the whole keep spraying Narcan up their nose until they get up. IV is the fastest route of medication absorption, and IV meds can be delivered via the following: by fluid bolus, by IV bag, by an IV piggyback, or infusion pump. Potential complications: too fast or too slow of a push. There's some medications that we have that you really have to make sure that you're pushing them at the correct pace. Adenosine. If you push adenosine slow, you're wasting it, right? Lasix, if you push it fast, you're going to cause problems. Narcan. People think that, I'm not sure how to word this. People think it might be funny to really blast a person with Narcan. I'm here to tell you that is not funny. It's not funny. And it's bad patient care, and it's dangerous. It's dangerous for you and dangerous for the patient. Please don't do that stuff. Needle sticks. The more needles we get out and have rattling around the ambulance, the more likely we are to get stuck with one. Patient reactions and complications can include the following: infiltration, occlusion, vein irritation, thrombophlebitis, hematoma, nerve, tendon, and ligament damage, and arterial puncture. When we start an IV, even if it's just a normal saline IV, we need to constantly reassess that and make sure that you're absolutely comfortable that whatever med, whatever fluid you're giving is going where it's supposed to go. Some of the meds that we give are really dangerous if you think they're going in the IV, and they're not. They're going into the interstitial spaces or somewhere else. It can be very dangerous for a lot of patients. So please remember to reassess. So assemble your equipment, BSI, select and check your med, confirm your dosage, aseptic technique, and we dispose of our sharps immediately. Intraosseous medication administration. IO has really changed a lot in EMS, hasn't it? It's a great tool. It seems like it went to first line for cardiac arrest, and now I see that the American Heart Association suggests trying to start an IV first. Follow your protocol, or follow your gut. If you take one look at that patient, you're like, we are not getting an IV on this person, then why waste your time? do the IO. The site, whatever site is in your protocol, the humeral head is most favored these days. It's the quickest. I personally wasn't too crazy about it. It always looked like it would fall out. It doesn't fall out. IO therapy is well documented in patients with shock, status epilepticus, and cardiac arrest. And as far as our protocol goes, it's a judgment call. If you think you need an IO, then the tool's there in your toolbox. There are some complications with IOs, though. You may fail to enter the marrow with extravasation or subperiosteal infusions. Through and through penetration. This can happen in children. We have to be careful when we start an IO. This isn't an IO class. We have to be careful when we start an IO. You don't want to support that leg with your hand. And that seems counterintuitive, but you really don't want to support that leg with your hand. It increases the odds of you going all the way through the bone. Osteomyelitis, which is rare in the short-term use, which everything we do is pretty much short-term use. Physial plate injury, we can avoid that by knowing our landmarks and being extra sure. Local infection, skin necrosis, pain, compartment syndrome, fat and bone microemboli have all been reported but are rare. I wonder how they figured out that there was a bone microemboli, like how they found that. Inhaled and nebulized. Most common are albuterol, ipratropium, the other meds that we use for our difficulty breathings. But other medications may be and can be very effective nebulized, including ketamine, fentanyl, and glucagon. Ketamine and fentanyl have been shown to be as effective nebulized as they are IV. Glucagon as well as mag sulfate show promise in some studies for difficulty breathing. I was actually on a call where Larry used ketamine by nebulizer for pain relief on a girl who had a very obvious knee dislocation and probably fracture, and it worked very quickly. It worked very well. I was pretty impressed with it. I've never done it myself personally, but I got to watch Larry do it. These rates of absorption are estimates because different meds absorb differently. These are for comparison. So we can see intraosseous and intravenous are 30 to 60 seconds. Inhaled 2 to 3 minutes. MAD device 3 to 5 minutes. Which is why we caution if you find yourself given that third dose of Narcan up the nose, folks, you got to really think about what you're doing. You need to move to a different route or something along those lines, or maybe look for a different reason. Intramuscular 10 to 20, oral 30 to 90. So you can see that there's a scale there. Medication errors are a big deal. Leading EMS organizations in the US and Canada have issued reports that include medication errors in their list of areas that require safety improvements. There's a lot of reasons we might make medication errors, guys. We give very high risk meds with intense time pressure and limited clinical information. In other words, kind of an accident looking for a place to happen. That's why we have to be good at this. We give meds in unfavorable conditions. We give them in the weather. We give them in loud environments where I might not hear, me checking my medication with my partner or something. I might mishear what he or she says. Drug shortages often change the dosages or cause the need for substitute meds or change the concentrations. Our ketamine, we had to change the concentration. Luckily we didn't have any, I haven't known of any errors since we had to change the concentration that we use, but you have to be really aware. And math errors. One study showed 9% of the providers in California self-reported a medication error in the last 12 months. In 2012, researchers found a 12.7% incidence of medication errors, particularly in patients who receive more than one drug or in those with a long transport time. If we're given too much time to play around, apparently, maybe we lose focus, so we have to be very careful again. Medication errors in pediatrics are very prevalent. That doesn't surprise me at all. but the numbers do a little bit. In 2006, researchers found that 65.8% of pediatric epinephrine doses in LA County were incorrect. In 2012, researchers found that in Michigan, a medication error occurred in 35% of children who were given a medication and had a weight recorded. So that's even with using the weight that you have, we're still having some mathematical errors. Or we're not doing a good job of estimating the weight. So medication safety, there's a couple different versions of this. There's 5 rights, 7 rights. I went with 6. You need to have the right drug, the right dose, the right time and interval, the right route, the right patient, and the right documentation. And these rates have been the root of drug administration safety since EMS began. They're still the foundation today, but they're only a foundation. They're not a sufficient barrier to prevent medication error alone. We have to be very diligent. You can't take a medication back out once you send it. So how do we assure medication safety? Have a formal system. Use a formal system to check medications prior to administration. Whatever it is. This county in Kansas implemented a formal system called the Medication Administration Cross-Check. And what it is it's a series of questions and checks and balances between the two partners so that they make sure that they agree with and they are both on board with the medication that's being given. In most systems, a Broslow tape or other device, as well as a calculator, are mandatory on ambulances. If you do not have a Broslow tape in your ambulance, you're doing yourself and your patient a disservice. They're cheap, and man, when the chips are down, you really want to have it. Use your voice. Repeat orders back. Sometimes simply restating that order alerts you to a problem. Like, if I tell Joe, "Yay, give me, 3.5 ounces of lidocaine," and he looks at me and says, 3.5 ounces. I'm like, whoa, what, you know what I mean? Just hearing that out loud sometimes is going to alert you. And if you think something is wrong, say it. If the other person is doing something and you're looking at it and thinking, man, is that right? Is that the right dosage or anything? Even if you're wrong, even if you're the wrong one, man, make sure you say something. That's serious business. Again, once you put a medication in, you can't get it back out. Practice drug calculations in real life scenarios to simulate the stress of real calls. When you're doing an actual, like if you're doing SimLab or something along those lines, do the actual calculations in real time. Set up your drug kits thoughtfully and consistently. Avoid putting look-alike and sound-alike drugs together. And this one isn't written up here, but this is a pet peeve of mine. Don't change stuff in the ambulance. You can't just arbitrarily go and change things in your drug box. Other people use those drug boxes, use those ambulances. Everything has to be consistent. If you come in one day and you're like, man, I'm tired of the epinephrine being there, I'm going to go put it over here on this shelf, and my next call is something I need epi for, and I look and it's not there, those delays can be costly. They can be deadly. So don't just go arbitrarily changing things around in your ambulance, unless it's your personal ambulance. And finally, one of the best things we can do to ensure medication safety is get some sleep. EMS workers who report poor sleep are 50% more likely to report a medication error in the previous 3 months than those who are rested. And we all get plenty of sleep, right? How about a show of hands who's well rested today? Not me. So I tried to hustle through that as quickly as I possibly could. I actually saved you a couple of minutes, and I'm very sorry that it had to go so fast, but I really didn't want to keep you until 9:30 or anything. That said, I'm willing to go back through any, any slides or answer any questions that you might have. Please feel free. Went too fast.
One of the things that I want to emphasize is that, a lot of EMS providers think it's going to be great to mix drugs in the same syringe. and that's absolutely almost not allowed. A big thing is Haldol and Versed, and you shouldn't do that. We talked about earlier how you need to get the Versed on board first, and then the Haldol separately. But drugs can participate in the same syringe and cause particles. So please, if you're not familiar with the drugs, you shouldn't be mixing anything anyways. So please don't do that. That actually has big risks towards the patient, and that would be found against you as being negligent because you know not to do that. So I don't know of almost any drug that we can mix up together and give it safely. So except for like saline and diluting with ketamine or something like that. Yeah, intranasal ketamine works really well for pediatrics too. I had a ped patient who was broke his humerus on a trampoline at a trampoline park, and the first thing he saw me do was get a syringe out, and he started hysterically crying. He's about a 5-year-old patient, and I put the atomizer on it, and I atomized ketamine up the nose, and it worked great. We were able to literally do whatever we wanted to do with this patient's arm. We put it in a splint, and we were able to transport him to the hospital. So if your system isn't using nebulized ketamine, invite them to speak with us. We'd love to educate them on that. If you're not familiar with the drugs going up the nose, come to us, email us. We'll sit down with you or do a Teams meeting if you're not locally, and we'd love to be able to, share with you our experience and our best practices to make EMS life a little bit easier. So we have the resources out there. We have the tricks of the trade, and that's what we're trying to do is present them with you to you so that you guys can become experts in the field as well.
Any questions, comments, concerns? Complaints?
No.
Okay, well, we'll leave the page open for a little while. If anybody has any questions or anything, just shout it out. We'll be here monitoring this for a little while. You're welcome, Marcia.
Thank you, Matt.
So we will see you, what is today? Tuesday. We'll see you Thursday, 6 o'clock. Spread the word.